Signore, signori, je m'arrête là. Welcome to Campus Biotech for the conference and the workshop on brain health services for the prevention of dementia. I am Giovanni Frisoni. I'm a neurologist, and I have the pleasure and the honor of directing the memory clinic of Geneva University Hospital and University of Geneva, and my co-chair.
Good morning, my name is Gilles Ali. I'm directing the Lennart's Memory Center in the CHUV Lausanne for this common event, and welcome everybody.
We have the pleasure today of having a large audience with a number of authoritative persons, and it's my pleasure to welcome Monsieur Pierre Maudet, State Councillor for Health and Mobility of the Canton of Geneva, His Excellency Gian Lorenzo Cornado, Ambassador of Italy in Switzerland and in the Principality of Liechtenstein, Monsieur Bertrand Levrat, Chief Executive Officer of Geneva University Hospitals, Professor Nicolas Desmartines, Chief Executive Officer of Lausanne University Hospitals, CHUV, and Monsieur le Doyen of University of Geneva, Professor Antoine Gasbuller. Bonjour Antoine. Claudio Bassetti, former President of the European Academy of Neurology. Elena Moro, President-elect of the European Academy of Neurology. Cristina Messa, former Italian Ministry of Health. Consigliere Nicoletta Piccirillo, who may come, Consul General of Italy, and the directors of the Department of Rehabilitation and Geriatrics at the Geneva University Hospital, Christophe Graf and François Herman. It's my pleasure now to let the floor to Gilles Ali to introduce the first speaker.
So the first speaker is Professor Nicolas Desmartines. Nicolas Desmartines is the CEO of the CHUV. He's a surgeon, and we are very pleased to have a surgeon today with us to make this introduction. Please, Nicolas.
Well, Monsieur le Conseiller d'État, Your Excellency, Monsieur le Directeur Général du CHUV, Ladies and Gentlemen, Mesdames et Messieurs, chers collègues en vos titres et fonctions, mon cher Gilles, caro Giovanni, c'est un grand plaisir et un honneur d'être ici pour l'ouverture de ce symposium. Oh, sorry, I said I will speak in English. So it's a great honor and a pleasure to be here to share with you the opening ceremony of this great symposium. I would like to thank both of you because you are a great demonstration of how, in the best possible case, the collaboration between Geneva and Lausanne can work. We wished with my friend Bertrand Levrat and Monsieur le Conseiller d'État Maudet that it could be the case for other specialties, but you are a model, and I think we have to thank you for that. I must confess, I hesitated to come here and to say I forgot what I wanted to say. However, it's completely stupid because the disease about memory and dementia are something very serious, and I don't think it's the occasion to make a joke. We all know some people who forget the names, forget the numbers, cannot remember the faces, or are lost easily. And actually, in my opinion, it's very important that our friend neurologists can make the difference between somebody who is just tired and forget an appointment or a name, and the people who will start to have a very serious disease. I just would like to remember here that today in Switzerland, 1/3 of the disease are connected to dementia. It's just after cardiovascular diseases and cancer, of course. So congratulations for your collaboration. I wish you a fruitful scientific meeting, and I hope you will learn a lot of elements, because today we can say that the neurologists will no longer be just describing what they observe, but maybe we have the opportunity to start with efficient treatment. So thank you very much for your attention, and I wish you a very good meeting.
Thank you very much, Nicolas.
Thank you very much. It's my pleasure to ask my general director to bring le salutation de bienvenue des HUG.
Thank you very much. Hello, everyone. Once I made a speech on the official part, and then the young people who were there said, now that the boring part has passed, we can start talking about serious things. So I will be quick and short, but I hope it's not boring at all. First of all, I would like to thank you, because as Nicolas just said, you are exemplary of what we can do as collaboration between institutions. And what I would like to celebrate is the fact that by doing partnerships, we're stronger together. And this we all know in theory, but I would like to say it how much in practice it is true through Alzheimer's disease, but it's also true in other fields where working together makes research as an obvious thing, but also clinical approach, also taking care of patients better and stronger when we work together. And with the Memory Center in Geneva, what we managed to do is not only to work together with other institutions, and especially in Lausanne, but also work together with private donors and private-public partnerships. And this as well has been a possibility together to go further than what we could have done with only public money. And I think this is exemplary on how we should try to work in the future, and not only today, by working together, building bridges, being able to open doors and to work together. Because for patients, and as Nicolas just said, we know that thousands of patients are expecting you here in this room to find solutions for disease which affects not only the patients, but we know the burden on the families, on the relatives, and on the fact that it is not only a disease that is extremely putting a strong burden on society and on the people affected, but a disease that will evolve and grow in the future in terms of number. So I not only wish you a fruitful seminar, but I really wish you to make these ties and take the opportunity of such a meeting to meet people you don't already know, to meet people who will be new friends to meet, and a capacity to build bridges, because together we can be stronger. And these two gentlemen demonstrate how together we can reach better goals for science, for research, and most importantly, for our patients. Thank you very much.
Thank you very much.
Thank you very much.
Mr. Lebras. We have the honor of having the patronage of the Embassy of Italy, His Excellence, Mr. Gian Lorenzo Coronado.
Merci beaucoup, Professor. Thank you so much for convening this meeting, this event. I would like to thank HUG, CHUV, UNIL, Université de Genève et le canton de Genève de s'être associé pour organiser ce grand événement. Genève est dans mon cœur, comme vous le savez, Monsieur le Conseiller d'État, j'ai représenté l'Italie pendant 4 ans et demi en tant qu'ambassadeur aux Nations Unies. Et je suis heureux, maintenant que je suis à Berne en tant qu'ambassadeur d'Italie en Suisse, d'y revenir à chaque fois qu'un événement s'y déroule. No, thank you so much. It's a great opportunity. Italy is quite involved in research, also in this field, in the prevention of dementia. I think it's one of the main challenges of the future, because the life expectancy is becoming longer and longer, and the chance to have to deal with this kind of disease in one's life, especially after 100 years, is increasing. So it's extremely important to have a research made in this field, and thanks to the professors, the MDs involved in this field, I'm sure that progress will be made possible in the future and for future generations. Italy is ready to associate itself in this field. We have a very good relations bilaterally with Switzerland. We had a few days ago a meeting in Rome on scientific cooperation. So the contacts are quite intense, and we are ready to help you to create bonds with excellent centers in Italy, universities, clinics, hospitals. Whenever there's an interest from you, you want us to help you to connect and to involve institutions or even people, MDs, professors, let us know. We'll be ready and happy to support you. So I want to congratulate you for hosting this great event at Campus Biotech in Geneva. I wish you a great success. It will be a full day of speeches and of interaction. So I'm pretty sure that you'll be all very happy tonight once this event is over, and we look forward to reading the report as soon as it will be ready. And count on us for anything you might need in your contacts, officially also through the medical institution universities in Italy. Thank you so much. I wish you all the best. Buona giornata. Buongiorno a voi tutti.
Grazie eccellenze, grazie al suo attaché scientifico. And last but not the least.
Yes, I would like to thank Mr. the Ambassador because Italy gives us the best clinician and researcher in Switzerland.
He's mocking. He always mocks me.
C'est mon plaisir maintenant d'introduire Monsieur le conseiller d'État pour la santé de Genève, Monsieur Pierre Maudet. Je profite de l'occasion pour excuser l'absence de Madame la conseillère d'État de l'État de Vaud, Madame Rebecca Ruiz, qui aurait beaucoup aimé être avec nous aujourd'hui, mais qui ne peut malheureusement pas être là. Monsieur Pierre Maudet.
Merci, Excellence, messieurs les directeurs généraux, mesdames, messieurs, chers professeurs. C'est un plaisir pour moi de vous adresser quelques mots au nom de l'autorité politique, et je crois pouvoir le dire au nom aussi de ma collègue Ruiz du canton de Vaud. Je ne l'ai pas préalablement consulté, mais je sais qu'on est assez d'accord là-dessus. Alors, c'est difficile lorsqu'on doit faire un mot de bienvenue et qu'on est le quatrième, parce que tout a été en général dit. Mais j'aimerais insister sur 3 éléments qui me semblent particulièrement forts aujourd'hui et qui nous réunissent dans ce lieu particulier, iconique, qu'est le Campus Biotech. Premier élément, et les 2 directeurs généraux l'ont dit, c'est la dimension de collaboration. Rien ne peut se faire dans la recherche, c'est pas à vous que je dois l'apprendre, professeur, sans une collaboration accrue entre les chercheurs, mais aussi entre les entités, les institutions. 2 belles institutions, le CHUV et les Hugues, qui collaborent. C'est une démarche extrêmement positive que je veux saluer et soutenir ici. Et au-delà de cette collaboration des institutions, eh bien, c'est les partenariats entre pays. Excellence, vous nous faites l'honneur de votre présence. Vous nous avez rappelé l'amitié que vous portez à notre ville et à notre pays. C'est pour moi l'occasion de vous témoigner cette amitié en retour et de vous dire à quel point nous comptons évidemment sur la fine fleur de votre pays présente sur ce podium pour faire avancer les causes qui nous sont chères. Le deuxième élément, évident, mais je me permets de le rappeler ici, pour les acteurs politiques de la santé, la question des maladies neurodégénératives est centrale. Elle est centrale parce qu'elle interpelle quant à la gestion du vieillissement de la population, de son accompagnement, de l'impact que ça peut avoir sur l'entourage, sur les familles, sur la société en général. Et donc, ce genre de rencontre est évidemment nécessaire pour faire se rencontrer les gens, mais au-delà de ça, pour faire avancer les réflexions sur l'impact dans notre société de ce type de maladie et de notre façon de l'appréhender d'un point de vue médical, mais plus largement d'un point de vue social. Et puis le troisième élément, qui est en réalité celui qui m'intéresse le plus aujourd'hui, raison de ma présence prolongée, je ne vais pas partir tout de suite, au contraire, je vais vous écouter. C'est un élément qui touche à la fois aux politiques et à la question du financement, mais un peu à la philosophie de la médecine. Je suis un jeune ministre de la Santé, j'ai 6 mois d'activité dans ce domaine seulement, et j'ai été surpris, je le partage volontiers avec vous, de voir à quel point, évidemment, c'est les hôpitaux qui nous mobilisent, le curatif, la prévention tertiaire, mais à quel point, en contrepoint de cela, il faut envisager d'investir peut-être davantage, pas à la place, mais davantage sur la prévention primaire et la prévention secondaire. Et votre démarche, qui est, je crois, centrée sur ces aspects-là, est éminemment intéressante parce qu'elle doit amener également le monde politique à considérer l'importance d'un investissement financier dans de la prévention, donc anticipée, dans de la prévention secondaire notamment, et dans une capacité d'investir intelligemment en amont pour ne pas devoir dépenser davantage ensuite. Et au-delà de l'aspect financier, bien évidemment, de faire prendre conscience, c'est toute la vertu de ce colloque aujourd'hui, de l'acuité des maladies dont nous allons parler. Donc merci de rendre possible cette discussion. Je me réjouis de la découvrir. Et je me réjouis avec nos bras armés, que sont le CHUV et les Hugues, qui ont déjà jusqu'ici bien soutenu la démarche de pouvoir l'intensifier le cas échéant. Je vous souhaite un excellent colloque et une bonne journée ici au Campus Biotech.
Merci énormément, Monsieur Maudet. Merci. So now it's time to move to the scientific program. As you have seen the program, we will start with a couple of lectures. There will be a small change of the program. The first lecture will be by Philip Skeltens. The second one will be by Claudio Bassetti on the general picture dementia treatment and brain health in Italy, in Munich. I'm sorry. Yeah, this is what I wanted. It's my in Europe and in Europe. I wish it was in Italy. Then there will be in the afternoon. There will be a session for specialists who will share experiences. It's a preparatory. It's a session aiming to exchange ideas, protocols, and to enhance the penetration of brain health services for the prevention of dementia who are already in place and are needed to grow and expand. The day will conclude with a round table. The morning will be closed with lectures on what way we have developed in Europe. There was a couple of years ago we set up a task force that developed the protocols for to address the 4 pillars required to do dementia prevention, which are risk assessment, risk communication, risk reduction, and cognitive enhancement. And there will be speakers addressing each of these. Having said this, I will leave the floor to Gilles to launch the first session with Claudio Bassetti and Philippe Skeltons.
Thank you very much, Giovanni. So now we're going to open the scientific meeting, and it's a very great pleasure to introduce Professor Philippe Skeltons, who gave an impressive lecture yesterday on the future of the treatment of dementia. Today, we're going to have the opportunity to share with you your view and our question. So please welcome Professor Philippe Skeltons.
Thank you very much. And I would like to, thank you very much. I'd like to thank you very much for having me again. And for those who were present yesterday, there will be a slight overlap actually. So, but as you know, in memory issues, repetition is key. So you will remember better if you have heard it for the second time. I would also really like to shout out to Gilles and to Giovanni, because they brought this audience, and I would say take advantage of it, because many of those are the crème de la crème in Alzheimer's and dementia field. So it's really outstanding. I'm Geneva. I don't know how you get this, but everybody is here, and you managed to get this through. So really, really congratulations on this. So ladies and gentlemen, dear excellencies, I would like to start with a little bit of so where we are in the treatment of dementia, notably, I think most importantly, Alzheimer's disease, and opportunities for prevention. And as I said to Giovanni, I'm really not a prevention guru. I'm not really I'm more into the drug treatments, but I think ultimately that's probably the end of the talk anyway. It's a combination of both that we finally need. These are my disclosures. I'm actually still, I'm full-time employed by EQT Life Sciences, and I'm also a member of the steering committee of EVOKE. And these are studies with semaglutide, and you know semaglutide is a drug. Actually, it's almost now like a lifestyle drug actually for obesity and diabetes, and it's also tested for Alzheimer's disease. So mainly, maybe at the end we only need one drug for everything. So just to speak and to preach to the choir that you all know already, dementia is not the same as Alzheimer's disease, and Alzheimer's disease is not only dementia anymore, because we are talking about Alzheimer's before dementia. But this is the spectrum that we are discussing. Dementia in general is caused by neurodegeneration. That's why it's key that neurologists are involved, because it's all about loss of neurons, loss of synapses, and proteinopathies. And there are different proteinopathies, as you can see here, alpha-synuclein, amyloid beta, of course, TDP-43, and what have you. And they give rise to different diseases that ultimately lead to dementia. If we focus on Alzheimer's disease, one of the proteinopathies that has been key for developing drugs against is amyloid, and the road to amyloid-based therapies has been a very long one. It started in 1906 with discovering sort of the basis, the amyloid plaques. Later on discovered that it was amyloid actually inside of those plaques. And the association between amyloid and tau became clear in the 90s, and ultimately the development of biomarkers, CSF biomarkers, PET biomarkers, and now also blood biomarkers, has been so instrumental to finally come up with smart ideas to develop drugs in a proper way. Without the biomarkers, it would not have been possible. So I think, like in oncology, you first have to be able to make a correct diagnosis, to make a sort of meaningful, get an insight of what's happening in the brain, actually, in terms of neurodegeneration, protein deposits, etc., and then develop the drugs. And that's why it took so long to actually develop drugs for Alzheimer's disease, because first we had to manage a proper diagnosis. And that's now what we can do. So we are making progress, and this is just a summary slide. We have aducanumab in June 2021, accelerated approval. It's now withdrawn from the market, as you have read. Lecanemab, fully approved by the FDA, Chinese authorities, Japanese authorities, and we hope to hear from the EMA in the first quarter or second quarter of this year. Donanemab, also phase 3 and phase 2 results, presented at AIC last year in Amsterdam, and we're waiting for the FDA to decide on full approval very soon. And then we have gantenerumab, one of the very first attempts to treat amyloid as a hallmark of Alzheimer's disease very early on, that unfortunately failed. I think we'll skip gantenerumab. I told you yesterday how long that story was and how difficult it was. I think the first thing that we have to acknowledge here is the discovery of lecanemab, which is basically, again, and that's so important to realize, we as clinicians and have to work together with basic researchers in order to translate knowledge from the patients to basic science and backwards to develop drugs. This was the discovery of Lars Landfeld. He saw patients that had a genetic form of Alzheimer's disease who developed a massive amount of protofibrils, not amyloid plaques. These patients are amyloid negative if you do a PET scan, but he developed an antibody against protofibrils, and that ultimately led to the discovery of lecanemab by a collaboration between BioArctic and Eisai. This is now fully approved because of phase 3 results. And this lecanemab targets the protofibrils, which is in the chain of coming from APP splice towards ultimate plaques. And in between, you have the protofibrils, ultimate aggregation into plaques. And what we now can use, as I said, we have these biomarkers to diagnose patients, to help diagnose patients. If the amyloid PET is positive, you're more likely to have Alzheimer's disease. But you can also show that an intervention like lecanemab actually reduces the amount of amyloid, to the effect that after 18 months of treatment, 80% of the patients do not have any amyloid visible on the scan anymore, which is really interesting. In oncology terms, you would say this patient is in remission because the marker has gone. It's no longer visible. So what do you then do? I mean, that's another discussion point. How do you treat the patients after that? But this is so significant that we can actually measure the effect of the drug, and we use it with amyloid PET scans. And it's a huge reduction of the amount of amyloid. And that translates ultimately in changing the course of the disease. Patients don't improve. Patients possibly don't even notice that they are changing, but the course of the disease has changed a bit. In this case, 27% slowing of the course in sort of, if you compare it to placebo, which, as we discussed yesterday, is probably, if you look at what oncology has done with the drugs in the oncology field, thank you, Frank, for this tip, it's actually almost the same effect as we have in many of these oncology treatments. So I think it's there to be, and it's probably very meaningful to our patients as well. But you have to explain how meaningful it is. And there's also these measures that we didn't really have put a lot of attention to, health-related quality of life measures that actually are also in favor of this specific treatment. And I was actually most impressed by these sort of results more than just the amyloid lowering, which we expected already, that the patients and carers actually can notice this difference in treatment by having a less burden for taking care of the patients is also, I think, meaningful. And also, you can measure the downstream effect of removing the cause of the disease. If you remove amyloid plaques, and by that you disturb actually this equilibrium by making plaques and getting the plaques. If you remove the plaques, you actually reverse that equilibrium, so you have less plaque load as well, but you also have less neurodegeneration and less tau later on, and you can measure this with t-tau and p-tau in CSF and also in plasma. This is really very interesting and meaningful to see that there is a downstream effect as well. And this is probably the reason why patients actually are less declining, because tau is really the driver behind all the symptoms and signs. We know, of course, that there are side effects, and I'm not going to trivialize these side effects. They are important. And that's why it's so important that neurologists take care of these patients, because you really have to do these images. You have to look at the images yourself, and it's not easy. ARIA is changes in the intensity on T2 images, on FLAIR images, and actually they may be very subtle, but they may actually grow in a couple of weeks' time if you continue the dose. So you have to be careful there, and you have to really work very closely with your radiologist and teach the radiologist how to look at these scans. So that's an important thing, but we can manage this. We can do this, like we did in oncology, like we did in other diseases as well. If you treat somebody with a drug that has side effects, you have to monitor the side effects, and that's what we have to do. And it's especially, we know also that there are risk factors for those side effects. If you're an ApoE4 carrier, you're more likely to develop ARIA quickly. If you have already small vessel changes on the brain scan, on the MRI scan, you're also most likely to develop ARIA. So those are things you know already. You can anticipate whether patients will develop ARIA or not. Now, of course, intravenous, these treatments are all intravenous. And so you have to go back every 2 weeks to a clinic or to a center especially dedicated to do this intravenous sort of thing. And that's, of course, not sustainable for the future. It's expensive, it's burdensome, and it's not sustainable. So companies are working on alternatives. And this is a very recent slide on CTAT, actually. Lecanemab in a subcutaneous formulation, you can do it yourself, or your caregiver can do it actually in a weekly bolus of lecanemab subcutaneously. It gives actually a very nice sort of level. Sorry, in PKPT terms, it's actually better than just a peak when you have an intravenous intervention. You give a very sort of almost equal dose over a couple of hours of time when you do it subcutaneously. So this is the future, and this is being worked on as we speak. So Lilly also enters the market now with donanemab, and this is basically a monoclonal antibody, but this is directed against a very toxic form of amyloid, pyroglu A-beta. And this is a very special form. It's post-translationally modified A-beta, which doesn't happen in normal aging. So it's only and only present in Alzheimer's disease. It's very specific for Alzheimer's disease. And also, it is also in the amyloid in the vessel wall. Hence, if you remove it, there's also more likely that the patient will develop ARIA. But you see, the amyloid PET, just as the other study, actually, it removes amyloid to a great extent, to the effect that 80% of the individuals after 18 months of time were PET negative. Also here, global disease severity. In this particular trial, they applied a precision medicine approach with a low tau group and an intermediate tau group and a high tau group. And tau PET you can use to sort of measure the amount of downstream pathology. So where is the patient on the trajectory of having a very early disease to very late disease? You can use tau PET for that. And if you focus on the patients who have less tau in the beginning, they actually do better. They have more amyloid removal, and they also have a more sort of effect on this CDR sum of boxes score, a clinical rating scale for the severity of the symptoms and the function in daily life. So a precision approach. Here also the downstream effects on p-tau in CSF and plasma are also very noticeable. So it does really something. Of course, here again, as I said, ARIAs twice as much more common in donanemab than it is with lecanemab. So if this is approved and we ultimately can use it, then we have to have choices, to make choices, whether you treat with lecanemab or donanemab. But for both, it counts that you have to be careful with ARIA. This is another thing, and I mentioned it yesterday because this is the next thing that we are seeing. So one of the issues has always been if you do an infusion with a monoclonal antibody, it enters the brain to a very small amount, less than 1%. And then you have to give massive doses, 10 milligram per kilogram every other week. And if you can reduce that amount, and also subcutaneously you can reduce that amount, that was really very helpful. And perhaps you can dose every 4 weeks or even every 8 weeks, if you are able to enter the monoclonal antibody into the brain more efficiently. And this is actually sort of possible with what we call transporter proteins, like for instance, the transferrin receptor, which is on each and every cell in the brain. And if you open up this sort of blood-brain barrier, there's 8 times as much of the antibody in the brain as it is without this transporter. So you have the transferrin receptor, you have CD98 receptor, there are different transporters that you can use. And this is now sort of one of the hottest things that are sort of being tested in this space at the moment. So you can see already in this graph, I hope you can see it on the right, that with the smaller doses of the same gantenerumab that failed in all phase 3 trials, but with the smaller doses in a very short time period, already 12 weeks of time, you saw a massive reduction on amyloid PET. So quicker and a lower dose. That's actually sounding really very promising. So we have to see how this plays out. End of March, Roche will come out with more data on other dose groups as well. So Lancet last year actually said to the clinicians in the audience, we have to get ready. We have to get ready. Healthcare systems have to get ready. And I think that's also a topic of today. How do we actually sort of get our healthcare system ready for patients who are willing and to undergo treatments if they are sort of suspected of having Alzheimer's disease? So I really predict that ultimately, in some years' time, people will come earlier to the clinic, as they already did in the last 10 years. When I started in clinic, people came with mini-mentals of 12 and 13, and the GP said, is there dementia? And nowadays, people already come with subjective complaints. A third of our patients that come to the memory clinic have subjective complaints only. That's why Frank Jessen actually designed the concept of subjective complaints to get a grip on this particular group of patients. But in the future, people will also come to brain health clinics without any symptoms, without any complaints, because they say, well, am I eligible for these therapies? Because if I have amyloid, I want to get it removed. Are there other issues? And as I said, I'm not an expert on this. Mia is here in the audience and she knows everything about this, and you will discuss this today. There are other factors as well. And the amyloid gurus, of course, they're always accused of saying, well, you only focus on amyloid. There are other things as well. That's true. There's co-pathology, there are risk factors. There is a lot of other things that you can do. These are the 10 risk factors that are now identified. Some of them are modifiable and some of them are not. Age is not modifiable, unfortunately. ApoE4 is a risk factor. It's the largest risk factor, and it's also considered not modifiable, although that's probably not true. There are gene therapies under development now that actually are able to transform ApoE4 homozygous individuals into E4, E2, or Christchurch mutations put in instead of one E4. So there is a future here also for gene therapy for ApoE4 carriers. So it makes it into a modifiable risk factor. But there are other risk factors like hypertension, education that you can modify, of course. And that's why there are multi-domain interventions. And I'm really not sort of, I allow myself to speak on this, but it's really not my work, of course. It's the FINGER study, the MAPTA, the PREDIVA study, the Look Ahead to Sprint Mind. To be honest, many of them actually failed. We know the FINGER study was successful, and that led to the FINGER's worldwide studies that are going on everywhere. It was a positive study, but to be really honest, the effect size was, of course, small. And it was especially an effect on the executive function and not on memory. But there was a positive effect of this specific intervention that Mia put together. But many of the other studies actually failed. But if you look why they failed, and that's always important, is there's perhaps a subgroup who really did respond. I mean, that's the secondary analysis. Interestingly, in the finger study, the main driver of the effect was actually the ApoE4 carriers, which makes total sense because they are the ones who have the largest risk. So if they do exercise and diet, etc., for them it's even more important. And yes, there is even an effect. In the MAPT study, the effects were only seen, that was an omega-3 multi-domain intervention study done in France. It was only seen in those who had, in a post-hoc analysis, were amyloid positive. So that sort of interventions, secondary sort of lifestyle interventions, if you want, they only are really effective if you already have a risk for Alzheimer's disease, which makes it yet even more important that these patients with risk for Alzheimer's disease come to your clinic. The PREDIVA study in Amsterdam study actually was also negative on the whole, but if you looked at a subgroup that had untreated hypertension, yes, it's even possible in the Netherlands. There are patients who are not treated for hypertension. In those, there was an effect. If you treated the hypertension, there was an effect on the primary endpoint, which was dementia ultimately. So here again, you can see the MAPT and the finger study, the effect in the ApoE4 and the respectively in the amyloid positive carriers. And this is a figure that Giovanni produced, of course. You know that of all the risk factors, of course, we know that ApoE4 is the most important risk factor. And of course, having amyloid in the brain is the risk factor par excellence to get Alzheimer's disease, unfortunately. Interestingly now, and this is probably, you cannot read it, but this is a study that just came out. So the MAPT study again, here interestingly, this is a lifestyle intervention study where they use the blood-based biomarker, the p-tau that I mentioned earlier, to measure the effect and to see whether there was an effect of this multi-domain intervention on this blood-based biomarker. So interrogating whether the effect was actually in the disease itself. And this was negative. So there was no effect of the multi-domain intervention on the blood-based biomarker. So there was no direct effect on amyloid pathology. So that's interesting. So there was an effect, but it was not through the route of doing something on amyloid pathology. So it did work on amyloid PET positive patients, but it probably didn't work by influencing amyloid itself. So just to conclude, and I think you will discuss, and I hope I give you some inspiration to discuss the concept of brain health clinics, because I think patients, subjects actually, will come to these brain health clinics in order to be informed of what to do and how to prevent disease in the future. If there is a disease present with these blood-based biomarkers that we will discuss probably also, you can determine whether patients are at risk for developing dementia. So what to do? Are we treating all of them with monoclonal antibodies? I don't think so. There have to be other drugs and there have to be other interventions, especially in that stage of the disease. But let me remind you again, we are just, and that's so exciting, and that's why it's so important that we're here together. We're at the very, very start of a very exciting new period in dementia research and clinical care. Thank you very much.
Thank you very much, Philippe. So we have the time for one or two questions in the audience. Yes.
Thanks. Great talk, as always. I think we have to be cautious about interpreting outcomes like a plasma p-tau 181 marker. Plasma p-tau 181 probably won't be used in the next year or two or three, but p-tau 217, depending on which assay, will be. So I think we have to be cautious and reserve judgment for multimodal interventions because we weren't using the right tools to define whether or not they're effective in different cohorts.
Well, I think you have to be careful. I mean, it's everybody talks about p-tau 217. It's the champion in the blood-based biomarkers, but 181 is not really that much sort of worse than that, I would say. There are small differences. If you ask Charlotte Teunissen, there are differences, but I think on the whole, I mean, this was just an experiment to see, but I would challenge you if p-tau 217 was used in this particular study, whether there would be an effect. I think that's what you're aiming for, and I'm not sure whether that's the case.
Stay tuned.
Stay tuned. But it will be, yes.
Yeah. So yeah, thank you so much, Philip. And one question I was also thinking about the gene environmental interactions, the same thing that we need to be quite careful, I think, when we are interpreting the findings. So in the FINGER trial, the stratified analysis ApoE4 carriers seem to get more benefit, but I would not say that ApoE4 non-carriers are not benefiting because the interaction term was not significant. So we are not powered to really see that. The message, what I normally say is of course beneficial for all, but the good news is if you have the genetic background, you may benefit and you may maybe benefit even more. And here again, we need much larger studies, both I think for the biomarkers and these gene environmental interactions.
That's why I said we're just at the start and sort of not at the end. But I totally agree. But I think I share the good news is indeed because those ApoE4 carriers, and nowadays it's much more sort of almost in fashion, especially in the US, to get yourself genotyped. I got a letter yesterday of somebody actually living in Amsterdam said, I'm a homozygous, what should I do? And the only thing you can do now is say, well, do a lifestyle intervention, because we know, based on your studies, that there's even sort of a higher, I would say, likelihood that you will benefit from the intervention.
So we move to the next speaker, Giovanni.
Yes, the next speaker will be Claudio Bassetti. Claudio is the Dean of the Faculty of Medicine at the University of Bern and a former past president of the European Academy of Neurology. Claudio has led an initiative in Europe to build a brain health plan. So it's about brain health in general. Dementia is a part of the brain health. Claudio, tell us about the European Brain Health Plan and the Swiss Brain Health Plan as well.
Your Excellency, distinguished guests, ladies and gentlemen, it is a great honor and pleasure to be here. And I would like to congratulate Gilles and Giovanni for putting together this exceptional meeting. It is indeed timely to talk about advances in early diagnosis and treatment of dementia. But I'm very happy that you also put an emphasis on the need of prevention. It is obviously for us clear, but maybe not for the larger audience, that if we will not concentrate also on promoting prevention of dementia and beyond dementia brain disorders, we will possibly, if not even probably, not able to take the challenge of the increasing burden of dementia and other brain disorders. Now, let me tell you why I believe that besides the precise prevention that was actually illustrated brilliantly by Professor Skeltens, we need also a more general approach to prevent dementia and beyond dementia brain disorders. So I think we need to think about promoting brain health and prevention of brain disorders actually from birth. And this is what I would like to illustrate today. Now, the background should be known to us, but in fact, the figures are not well known or were not well known until very recently. And actually, Professor De Martins mentioned that 1/3 of the population has something to do with dementia, probably meant brain disorders or neurological disorders. Now, these are figures that have been published very recently in a quite respected journal. So the figures, I think, are reliable. And they show that 1/3 of us, 1/3 of the general population suffers today of neurological disorders. Not all of them suffer of dementia, obviously. It can be headache, can be something else, but 1/3 is suffering of a neurological disorder. And if we think and talk about brain disorder, we should include also psychiatric, mental disorders, and actually the figures are quite similar also for psychiatric mental disorders. Now, surprisingly enough, recent data have shown that neurological disorders and mental disorders are actually accounting for a big burden in terms of mortality, but also disability. The daily is one way to measure the impact and the burden on the life of our patients. And in fact, the very recent analysis, taking into consideration over 100 countries and almost 200 diseases, have shown that neurological disorders are the #1 cause of daily and actually the #2 cause of mortality worldwide. So the background is that we have an increasing, very high and increasing burden of brain disorders. It's not only about the prevalence, it's not only about the loss of useful years of life. It's about not only about mortality, but the sufferance, the stigma, and eventually the cost. And in fact, we don't have very good, I would say, overarching analysis of the cost of brain disorders. The last one that really included most brain disorders is shown in the part 3 of the figure. This was a European study showing that, in fact, brain disorders, and here I include neurological and mental disorders, account for more costs in Europe than diabetes, cancer, and cardiovascular disorders together. So I want to stress the fact that we deal with a huge burden, and not only because of aging, but also because of aging, we will have to deal with an increasing challenge to do this. So this is why we need also to prevent them. And in fact, this is the good message, and we heard already few novelties about how to prevent dementia, but also for other brain disorders. I will come back to this. But eventually what we should, and most of us are actually brain specialists here in the room, we should actually tell the community that brain health and the brain are essential for our lives. And, once Woody Allen was asked, what is the most important organ of lives? And he actually said, the second one is the brain. And I would assume the first one is actually the brain, because it's through the brain that we can realize our potentials, we can communicate, and eventually we decide what the society does. And this is something that we should promote. It is about brain health, it's about the brain power, and eventually the brain capital. Now, I think that these two publications of the WHO have actually set the stage for changes. Obviously, the dementia community started much before, but the importance of brain health as a whole has been certainly stressed by this important paper, where for the first time also a definition of brain health was suggested, which I will come back in a moment, which stressed the fact that if we want to prevent brain disorder, we should not start when we have the first symptoms or when we think about preventing, when we're getting old. And actually, the paper stresses the fact that promoting brain health actually starts in pregnancy and in early childhood. The second document is shown here is actually the paper that for the first time set neurological disorders as a priority worldwide. And this paper has been approved by the General Assembly in May. And actually, this is the first time that WHO has proposed a global action plan on epilepsy and other neurological disorders. The fact that epilepsy is stressed as historical reason, but the key message is that the WHO says for the first time, well, neurological disorders are a priority and we need to do something. Now, the brain health definition, I will not read it, actually stresses what I told you before. We should not think about brain health only in the context of the aging brain or the aging population, but we should have a life course or an approach across the entire life course, which includes obviously many factors in pregnancy and early childhood. And the fact that, and this is the second key message of this paper, brain health is not only important to, to talk about brain disorders, but also because it is essential for the way we function and the way the society prospers, and eventually also for economy. Now, at European level, looking at overarching approaches, I was involved with my colleagues at the European Academy of Neurology in launching this European campaign on brain health, one life, one brain, one approach, stressing the fact that if you need, or if you think about primary prevention, you need to have an overall approach. We cannot just dissect prevention in each single disease. There are plenty of overlap. If you treat hypertension, you will decrease the risk of stroke, but you can decrease also the risk of dementia. And also we have to think about having an holistic approach between neurological and mental disorders. You know that 1/3 of our stroke patients have depression. I don't know the percentage in dementia is probably around 20–30%. So we need to have, when you think about particularly primary prevention, to have an holistic approach, while when we are targeting specific disease, we need to be as precise as possible. I would like to mention that also the European Brain Council is working on these topics, and these are important initiatives that create also a network around the need of more activities and more support to treat, diagnose, but also to prevent brain disorders. Now, if you look at the nations, I'm aware of only 4 brain plans. Again, I'm not talking about single diseases. And the first one was actually launched in Norway. The second one in Germany. This is the Deutsche Hirnplan, which has, as most of these plans, an holistic approach linking neurological and mental disorders. And we were actually among the first one, and Finland has launched its own plan also last year. Now, I'm aware of many other countries, including Italy, and I know that few people, including Dr. Frisoni is involved, but other people are launching or thinking about launching an Italian plan. Now, let's talk about the Swiss Brain Health Plan. So the letter of intent, the call for action was actually published in 2022, and it took then 1 year to create a momentum. And certainly the fact that the Swiss Federation of Clinical Neurosocieties was involved helped us to involve most of the people needed for such a plan. In fact, eventually 18 societies are supporting this initiative. 15 of them are within this Federation of Neurosociety. I'm speaking about neurology, psychiatry, biological psychiatry, stroke, and many other specialties. Now, the paper was published just a few months ago and actually reflects this concept and also this idea of creating a momentum across disciplines to raise the attention for more actions at the political level, at public health level for diagnosis, treatment, but also prevention of brain disorders. Now, we had the kickoff in November in Zurich. This was extremely well attended, and we were happy to have the support of the presidents of the Confederation. Now, unfortunately, after we started creating connection with him, he retired, so we have to start again with a new president. But we were very pleased that Mr. Berset wrote a very supportive introduction and welcome. And a person that is staying is Mr. Engelberger, actually the president of the Confederation of the 26 health ministers in Switzerland, who is very enthusiastic about promoting brain health and with whom we will continue working. And certainly this, as Skelton said, is only the start, not the end of our effort also in Switzerland. Now, what are the strategic pillars of our initiative? Well, we want to talk more about, we want to raise the awareness about brain health and brain disorders. If you think about our colleagues in hospitals, our colleagues in academics, if you think about also the general public, the awareness not only about dementia, but also about brain disorders in general is limited. Now, we have a problem with the working force. I mean, in Switzerland, probably less than in other countries. I'm not thinking about the less advantaged countries, but overall, we have a problem in educating people working to prevent, diagnose, and treat brain disorders. So we need to promote interprofessional education and training. We need more research. And Giovanni also always stressed me in saying, well, you need to talk about precise prevention. Absolutely. And this is related to the need of understanding better the mechanism of brain disorder. You can be precise in prevention if you understand what are the mechanisms. And although we know a lot about, let's say, dementia and prevention of dementia, there are a lot that we cannot explain. And actually, the paper in Lancet Neurology said that maybe, how much? 50% of dementia can be prevented. It means that 50% is not understood. Then we need to talk about public health approaches, and eventually, last but not least, the patient relatives must be involved. Let me show you some examples of what we are doing. The campaign has just started, and actually, I'm hoping that this year we will have more to present. Now, we actually launched several activities, and we are invited in participating in different national activities. This is the first one, Giovanni. Thank you, Gilles. So we're very happy to be here also with our activities, but there will be more coming up around the topic of stroke, sleep, and others this year. Sleep is a very frequent group of disorders. They probably have a role in modulating also the risk of dementia, stroke, and other brain disorders, but it's completely neglected. The 4 behaviors that we should think about are not the eating behavior, is not only exercise, mental and physical, but also sleep. And we have planned under the umbrella of the Swiss Brain Health Plan also a think tank where we will look at what we know, but also at what we do not know about the role of sleep and sleep disorders as driving forces, modulators of brain disorders. And sleep health is a new concept. So we can promote brain health through sufficient and good sleep. Then we will launch, and I'm happy to say this has been an activity centered around our faculty, our university. We will launch probably the first international study, a course, a certificate of advanced studies on the topic of brain health. This will be open internationally, and we do have already a very large faculty to which some of you are already members, and we hope that this will also create a new momentum around not only brain specialists, but also other specialists around the need of prevention for brain disorders. We need more research. If you look at the data in Switzerland, if you look, I don't know the data in Italy, but if you look at the data in Europe, the proportion of funding that is devoted to the research on brain disorders and oncology and cardiovascular is just too little. It's around 1 to 10 or 2 to 10, the proportion. So we need to promote more research on all these potential factors that eventually determine the presence or not of a brain disorders. Now you see that in this cartoon that we have published a couple of years ago, we recognize several factors. Some of them are specific, some of them are less specific for, let's say, for instance, dementia. Now, I think when we talk with politicians and with other important stakeholders nationally, we need to present also solid data when we talk about the burden. And this is why we have launched in Switzerland a very tight collaboration with the IHME. This is this institute in Seattle, actually supported by the Bill Gates Foundation, which actually is able to provide data on mortality, but also on daily and costs of brain disorders in different countries. So this is one type of analysis that we are gathering in the context of our Swiss Brain Health Plan. And here we look at the daily as one measure of the burden. And you look now at different ages from actually birth until, let's say, the age of 100. And the different colors show you the burden of brain disorders here, again, in this representation, neurological and psychiatric disorders together. Now, you will see at one glance that mental disorders, not a surprise, are very prevalent and very important as determinants of dailies in earlier phases of life, the blue bars, but then the neurological disorders, including dementia, but also stroke. Interesting enough, in this representation of the IHME, stroke still not within neurological disorders, because the WHO also did not include stroke until recently into the category of brain disorder and the tumors. And you see this is actually a very important type of analysis that we will provide to our community and also the politicians in Switzerland to convince them that there is a burden that has to be taken care of. Now, the fourth one is a public health approach. This is probably the most complex part of our activities because we depend on the interest and support of multiple and different stakeholders. We are planning workshops, the first one in March, to define priorities and targets. We want to define precise targets and then show that we are doing something. So we are thinking of monitoring the burden, maybe with such approaches I've just shown, and then monitor intervention, look how this burden is diminished. We need to promote primary and secondary prevention, general prevention and specific prevention, research priorities, and we want to hear from the patient and patient representative what their priorities in this context are. And this is the last part of our strategy. So it's work in progress. Some things are still to be defined, but we have an enthusiastic group of people, and Giovanni and Gilles are part of this activity in Switzerland. I think we need to promote not only specific interventions as we discussed today for dementia, but we need to have an overall approach to decrease the burden of brain disorders in general. And in December, we'll meet again in Bern, and by then I hope we will be a little bit more concrete about what we are doing and what can be achieved. Thank you.
Thank you, Claudio. I believe that it's very relevant for dementia to be included in a larger effort. Cognitive health is relevant, but if it's not in a larger context of a stroke, brain injury, epilepsy, we will be weak. There's a time for one or maximum two questions from the audience before we move on to the next session. Dina.
Yeah, Dina from Geneva University. Thank you very much for your presentation. I am wondering that if we want to prevent the brain disorders like we are preventing diabetes or cardiac failure, we need to start much earlier in the primary care. Maybe if we are talking about the memory centers, it's a little bit late and we have the risk to select subjects very robust and with a high social cultural level. Then my question to you is how you are thinking that we can, in a populational way, do this prevention of the brain with the GPs? Thank you.
Well, this is a crucial question, and you're completely right. Our, if I may say, philosophical approach is exactly what you say. If we want to prevent brain disorders in general, we need to start early. And as we all learn as children to do like this when you get up in the morning, we should have an approach where we have something that we do for our brain, and this should be a current practice. And I think this is what is completely lacking. If you look at what the society is doing in general, we're going exactly in the other direction. The obesity is increasing, sleep disorders increasing, physical activity is decreasing, the consumption, of technical and virtual surfaces is increasing. So I think we need to have an approach, and to how to reach this. This is the big challenge. First, you have to have an awareness of the fact that we are dealing with a huge group of disorders, and then you have to design, intervention. So I cannot answer this. The discussion about how to define priorities and also specific targets is still matter of debate in our group, but hopefully by December we will have some specific suggestions.
And may I add, Claudio, that the group is very aware that about the need of liaising the hubs, the dementia prevention, stroke prevention, epilepsy prevention hubs at the secondary prevention level with the primary prevention level at the community.
Sure. If you look at our paper, in fact, this is what Giovanni is alluding to. We have also figures where we actually conceptualized a potential approach where we would have, let's say, a Swiss brain health plan overarching the entire, country, so to say, with maybe also the creation of specific national activities. But then it boils down, particularly in primary, prevention approaches to the contact with the GP. So it's a huge project where GPs play a central role.
One last question.
Hi, Lucas. I'm Lucas from Geneva University. Thank you for these very exciting presentations by Professor Skeltens and Professor Bassetti. So the novel treatments and the brain health plan brings us to a very exciting era in dementia treatment, obviously. But we should not forget also the elephant in the room that we were talking about is the high risk of ARIA with the treatments of immunotherapies. Some of it is asymptomatic, but some of them are pretty severe cases. And I think we need to also come together in terms of this topic and to educate all the actors in the chain of dementia treatment and prevention, how to better detect ARIA and how to better prevent these amyloid-related imaging abnormalities. Meaning that we will have more and more patients treated with these new therapies. They will come to emergency departments, with sometimes non-focal symptoms, but sometimes with focal symptoms. So we will need to have, emergency department physicians, neurologists, neuroradiologists, more and more capable to better identify patients for anti-amyloid treatments, better detect ARIA, and to do better research on it. So I think Brain Health Plan is also a very good platform to educate about these side effects?
Well, I have no comments about Dario. You have said everything, so I don't have any details to add. But I think what you stressed is what I believe is very crucial. If we want really to promote brain health in general, and including primary and secondary prevention and specific and non-specific prevention, we need to refine the networking across the disciplines. I mean, we are all hyper-specialized, and this is important. To design, to understand specific targets, we need to be highly specialized. But for these type of activities, we have to find again the way of working together. And one of my hope in Switzerland is that the bridge between neurology and psychiatry will be reconstructed. We cannot diverge further. So we need to work together. Thank you.
Thank you, Claudio. And we can move on to the next session that will be chaired by Bruno Dubois.
Thank you very much. Thank you, Claudio. And Philip, after this interesting antipasti, we have to move now to the main course. And the main course is, as you know, it's to speak about this brain health services. And I like the subtitle, The Next Generation of Memory Clinics. All of us here, if we are here, it's because we are working in very high level of memory clinic. We have learned during the last 20 years how to improve our, I would say, diagnostic performance. We now use biomarkers who are very, very good in the field of diagnosis and care of patients with Alzheimer's disease or dementia. But now we have to work on a new job, which will be to prevent these kind of things. So I think it's important to think and to work about what should be this new brain health services. And it's a pleasure now to introduce this new session. And I would like to congratulate my dear friend Giovanni Frisoni, who is for me really a visionaire because since several years now he's thinking about what is the concept and what is the roadmap for this new brain health services. And you will summarize your thought about that. And thank you very much for all the job you have done in this field.
Thank you, Bruno. I've been working for 22 years in a psychiatric hospital, and visionaries were not always a positive adjective. I will try now to set the stage for what will come afterwards. And actually, I absolutely have to move when I talk, else I become dumb. I will give you an overview, a bird's eye overview of what will come afterwards, of what my colleagues will address in greater depth. Let me start with the observation that a patient, we already have the clients who want dementia prevention. Society is already asking for it. We see patients, yesterday I had my consultation day, 6 patients out of 6, they all had cognitive complaints or cognitive concerns. Cognitive tests were all normal. MMSE 2930, clock drawing test 10 out of 10, episodic memory test fine, Dubois 5-word test 19 to 20, all 6 of them. So there's already patients coming to our memory clinics asking answers to their concerns and worries. But we don't have protocol. In current memory clinics, what we tell these patients is, or what we can offer based on what the National Health Service reimburses, or based on what insurance reimburses, is, well, you're fine. Cognitive, they may undergo a cognitive battery, they may undergo an MRI scan, everything's fine. You go home, be happy. Of course, you should improve your lifestyles, but that you don't need to go to a memory clinic to learn that you have to do physical activity, to the Mediterranean diet, Italian, possibly. You really don't need that. So we have preciously little to offer to these patients. This is an example, not taken from yesterday, but Mr. Smith, 62-year-old man, engineer, CEO of his own enterprise. He complains with memory decline. Family history of dementia. Well, I don't know where my family, we've been moving all over the place. I don't have ties. Difficulty retrieving proper names of people and places. Treated hypertension, type 2 diabetes, some quotes modifiable risk factors. Cognitive performance perfect. But he's also he's also E44, an E44 carrier. What do we have today? What's the scenario today? Well, we have the primary practice. Dina Zekri was mentioning that. What do they have? Well, they have the treatment of the vascular risk factors, as we all know, and unstructured lifestyle recommendations. What MIA has been developing in a very structured format. In the general practice, they give unstructured recommendations. And then we have the memory clinics, right? What the usual memory clinics, where for these patients, we have little or nothing to offer. What we're missing is the layer in between, the layer where we evaluate the risk of these patients to develop dementia. We tell them what their risk is, and we put in place interventions to reduce the risk of dementia. And this is the topic of this of today. You heard about Philip showed studies showing some efficacy. Mia has the worldwide finger showing, in her original paper, she showed efficacy of lifestyle interventions. But you may always be skeptical about studies. There's plenty of studies all over the place. Sometimes some are published in the Lancet, others not. But there's one observation which is critical to me. Dementia prevention is already in place. So what I want to say, the message that I would like to deliver here is that skepticism about the possibility to prevent dementia is unfounded, because dementia prevention is already going on today. This is a slide taken from one study of many. There's 4 or 5 observations, 4 or 5 epidemiological studies all over the world, which have shown that my risk of becoming demented today, at my age, 62 and something, almost 63 years, is lower than the risk that my father had when he was 62. Why is that so? Well, we do not really know, but probably better lifestyles, better control of vascular risk factors has played a role. And this is something that that's clear. That's it's not disputable. However, this does not mean that dementia will decrease, the burden of dementia will decrease in the future. On the contrary, because the aging of the population is increasing at a much larger pace than the gains that we're having thanks to better lifestyles. And probably we may also be next to the ceiling of lifestyle. You can only do so much in our Western societies, not necessarily in the world. So the challenge in Western societies is now to put in place programs which deliberately decrease dementia. We can no longer be happy with the gift of better lifestyles because we are wealthier, we have more leisure time. We must put in place, if we want to decrease the burden of dementia in the future, we need to put in place specific risk reduction programs. With this in mind, a couple of years ago, a European task force, some of the members are present in this room, convened to figure out how to put in place these programs of risk reduction. And we identified that this is the paper that we published last year. We identified the 4 pillars that I've already mentioned. Of course, you must, before reducing the risk, you must estimate the size of the risk of the person. You must evaluate all risk factors, so risk assessment. Then you have to communicate the risk, which is not trivial. Communicating a diagnosis is not trivial. Communicating a risk is even less trivial. Then you put in place risk reduction programs in those at high risk, not in those at low risk, only in those at high risk. But that may not be enough. Our patient, Mr. Smith, that I was mentioning, was not only asking to decrease his risk, but he was asking that his performance, his cognitive performance, may function better than at the moment, which is something different. That's cognitive enhancement. That's improving cognitive performance, which is already within normal limits, but making it even better. And these are the 4 pillars that we identified as constituents of dementia brain health services. This is the theory. What do we know? What evidence, what elements do we have to put these programs in place? Well, we have quite a number of them. Number one, we know the risk factors for dementia. They've already been mentioned. Here you have them stratified by genetic risk factors, happily, by the so-called modifiable. We can discuss a lot, the 12 so-called modifiable, but also brain pathology. Philip was mentioning that amyloid in cognitively unimpaired persons is a very powerful risk factor. As you can see here, this is a log scale. The relative risk of amyloidosis is 5, which is as large as having 2 copies of the E4 allele. And if you have amyloidosis and the signs of neurodegeneration, your relative risk is 20. It's huge. Of course, that doesn't mean that lifestyles, the traditional modifiables, are irrelevant, because if you have 3, 4, 5 of them, it's probably even worse than having just one of the biological ones. But the notion here is that we know the risk factors for dementia, and we know also the size of the risk factors, which is critical to prioritize the risk factors to intervene on and to put in place intervention programs. The other message of this slide is that we can also think of categorizing risk factors into 2 domains, into 2 categories. Those who are acting on the vascular side and those on the neurodegenerative side. I know it's a crude it's a crude categorization. There's a lot of interactions between them, but there's evidence showing that there's a vascular pathway to brain damage and there's a neurodegenerative pathway to brain damage. So if this is the case, there's a risk factors for one pathway, for the vascular pathway, and there are risk factors for the degenerative pathway. And this is preliminary to put in place interventions targeting the vascular ones and the neurodegenerative ones. I will not go into the details. I will just mention that the next lectures will address the issue of risk assessment. Will be addressed by Frank Jessen. The communication of risk, which is by us physicians perceived as a, communication with patient is not something that we're trained on. We're trained in pathology, in the clinical symptoms, but talking to patients, communicating is not something that we are very much trained on. But communicating risk requires specific expertise, and Leonie Visser will tell you something will give you recommendations on how to do that. Mia will address the risk reduction interventions focusing on modifiable risk factors, mainly the vascular domain risk factors. We will have a video from Jeff Cummings on prevention using pharmacological strategies. Giacomo Koch, who is an expert of transcranial stimulation, will give you will give us a talk on how to enhance cognitive performance in persons without cognitive impairment by using magnetic stimulation, electrical stimulation, and other strategies. Andrea Brioschi will give us an overview of cognitive training, which is not Sudoku. I always say that this is the questions that I'm always asked. Is a Sudoku with les mots croisés, crosswords? Is it good for my memory? Well, my answer is always that no, if you may or may not agree, you will become a champion of Sudoku, but it will not translate to daily life. At least there's no evidence that this is the case. And Andrea will give us a talk on structured cognitive training programs. So to wrap up, the patient or person that when they come to our clinics, they're patients. The patient that I was mentioning earlier on has two kinds of risk factors. He has vascular risk factors, but he also has degenerative risk factor. Alcohol abuse we can discuss. It may be on either side, but I would like to give you this message that we can consider developing programs separately for the vascular and the degenerative component. The task force has developed a roadmap, a 10-year roadmap. We already have evidence that I've mentioned very briefly that you will hear more. We already have evidence allowing to start building brain health services for of dementia. We already have some tiles of the puzzle. But there will be more technological advances in the future that will come along and will allow us to enrich or fine-tune or modify our patient journey. I will not go into the details here, but the next technological innovation will be blood biomarkers. They will be coming shortly, and once we have blood biomarkers, of course, that will be the ideal technological tool to do risk profiling. There may be anti-amyloid drugs. Lucas was asking a question on monoclonal antibodies regarding brain health. I don't think that monoclonal antibodies will be used for secondary prevention. We're talking about patients without cognitive impairment, without cognitive impairment. Secondary prevention programs require well-tolerated, very well-tolerated drugs. Think of antihypertensive drugs. I don't think that monoclonal antibodies will be the ideal drug. But there's small molecules that may come along with a significant anti-amyloid efficacy. To mention just a couple of them. So the message here is that we are just at the beginning of a long journey. And in terms of in communication to the general society, I believe this is key. We should not overpromise and to manage expectations. As you clearly, easily realize, this is where we are now. We are now where the vascular field was in 1945. In 1945, people the experts were not sure that hypertension was a risk factor for stroke. There was a debate in the community. There were people who were thinking, experts who claimed that treating hypertension, they had drugs, but they claimed that treating hypertension was meaning treating the manometer, as well as some people believe that today treating amyloid means treating the PET scan, Valentina's scanner, or treating the image, not treating the patient. They found out that this is not the case. They found out that with the Veteran Administration study, that decreasing blood pressure had a huge effect on the decrease of the risk of stroke. We may not have such an overwhelming success, but this is the scenario that we're aiming for, and that I'm sure that we will reach in due time. And with this, I thank you for your attention, and I'm open to one or maximum two questions.
Thank you very much, Giovanni. So we're going to start with one question from the chat because our friend online can ask a question. So the question is, do we have any evidence that prevention works equally according to APOE genotype, or would you expect a precision-based approach?
This question has already been mentioned by Philip Skeltens and by Mia. There's evidence that some interventions have are differentially effective in carriers and non-carriers. We still have most studies were not powered to see an effect, to appreciate an effect and interaction, but there's more work to do, and certainly the way is towards personalized prevention, because what we're talking about here is personalized prevention. This is certainly the way to go.
Please, Claudio.
Fantastic talk. We spoke, we have lots of lions in the room. We heard there is one elephant missing, and I would like to mention a second one, which is sleep. We know that sleep is fundamental for memory consolidation, nature science papers, humans, animal experiments. We know that sleep loss experimentally in humans and also in animals leads to cognitive deficits that may be then reversible. And we start seeing works showing that sleep apnea and insomnia may increase the risk of dementia. So since I'm not primarily involved in the dementia field, I would think that the community, before maybe discussing transcranial magnetic stimulation, could think about sleep as another lifestyle or behavior that may modulate, not in itself alone, but modulate the evolution of several diseases, including dementia.
Absolutely. Apologies for not mentioning that, but certainly in one of the, during this 10-year roadmap, we will need to include more risk factors. Sleep is certainly one of those for which there's significant evidence. It was not included in Livingstone's paper, neither the first one nor the second one. But of course, it's the glymphatic system that we know it's involved in the clearing of amyloid, and it's modulated by sleep. So it makes a lot of sense. I would say that the sleep experts should interact with the epidemiologists to try and study more sleep in the context of the other risk factors, because the issue here will be to study sleep together with the other risk factors, to the lifestyles and the biological risk factor. This is what we will need.
Giovanni, probably another missing point. You didn't speak at all about evaluation, validation of this kind of approach. It will be mainly clinical. We will need to validate this. So you have to think about how can we validate this intervention that we will propose.
Absolutely. The question is about the validation of the patient journey. We have a number of experiences. Craig Ritchie, who is in the room, I believe, I can see him. He has published a paper where he was outlining the validation pathway of his memory clinic. And I believe that we as a community should agree on a validation pathway of our brain health services, which means validating the patient journey. It's not a trivial notion, because even today, what's the evidence that currently active memory clinics are effective? There's some studies, but the methodological quality is very poor, because you cannot do it.
It's a real central point.
But it's absolutely a critical point that we will need to work on.
One last question. Yes, please.
Yes, thank you for a nice lecture. I have some very short question regarding some risk factor. Let's take, for example, sleeping for Claudio, the question. When we are health professional here, and I, for example, work 4-night shift still, even as professor. So sleeping quality, of course, during the working at night is not the best. So we have some subpopulation that, for example, nurses, they don't want to live unhealthy lifestyle. So they don't want to work this heavy night shift. So this is very unpopular when I talk like that with hospital director in Karolinska. He does not want to talk about sleep as a risk factor. And another with intervention, for example, hearing impairment, it came also intervention study. Very nice American study achieved. You probably, of course, read that. It came last year. That if you have population with heavy risk factor, a lot of risk factor, giving them 3 years intervention with hearing aids, it helped them. But if you have population that does not have a lot of risk factors, 3 years didn't change the pattern for cognitive impairment in this achieved hearing intervention study. So even we have nice G. Livingstone Lancet paper with a lot of risk factors, intervention are not so easy to really give us the good evidence. So if without goodwill, if we put this evidence in, like you really try to go through evidence, not so many evidence in this intervention still are in place.
Good point, but I believe that we will hear more about risk reduction interventions later on.
Thank you very much, Giovanni. So we have to move on, and it's my pleasure to introduce the next speaker, Professor Frank Jessen. We all know him. He is a director of the memory clinic at Cologne, and is well known for his works on memory, subjective memory complaint. Okay, so you will speak about the risk profile, please.
Yes, thank you, Bruno. First of all, a very great thank you to Giovanni and Jill for this great symposium, and also for Giovanni for setting up this initiative several years ago. So I will, you've seen that before, my disclosure slide here. What I will discuss now is what Giovanni introduced, risk profiling. So why do we want risk profiling in an individual for cognitive decline and dementia? First of all, to determine whether there are individual risk factors in a person, and also to distinguish between modifiable and non-modifiable, maybe for this particular person, modifiable and non-modifiable risk factors. To provide a risk score. I think we are not there yet to provide an individual risk score. It's not just summing up all individual risk factors. So I think the topic of risk score for an individual is still something we have to work on and validate. And finally, then is to inform the person about the risk and also, of course, to give advice on what to do afterwards. So what methods do we have? We have, of course, medical and family history, where we can find some risk factors. We have cognitive and psychopathological examinations, so cognitive testing, and, for example, screening for depression, physical examination. We have a lot of questionnaires and assessment instruments which are validated, which we can use. And of course, we also have technology like biomarkers, neuroimaging, and so on. So this is here from the paper of Giovanni. This is a list where we put together very concrete, I would say, proposals for assessing these 12 risk factors of this Livingston paper. And you can see that there are ideal ways of assessing a certain risk factor and more practical ways. So ideal ways are more technical approaches, maybe sometimes more costly approaches, more extensive approaches, and practical ones are often based on questionnaires and are more simple to perform. I will not go through each individual assessment here. You can, if you like, look it up in this paper. But in the end, we can say that we can assess all of these 12 risk factors with more or less validated and accepted tools. Then, of course, there are the biological risk factors. Genetic assessment of the ApoE genotype is, of course, very well established. And then we have a number of biomarkers. We have invasive biomarkers like CSF and expensive biomarkers like PET. And we also have upcoming blood-based biomarkers, which have been mentioned before. So we have the full instrumentarium, I would say, for assessing these 12 risk factors. So in the next part of my talk, I would like to present to you an example of a risk profiling pilot study, which we did at our Dementia Prevention, Alzheimer's Prevention Center in Cologne. Study is called Inspiration. The idea was to assess not only these 12 factors, risk factors, but a more extended number of risk factors, also not really fully yet validated risk factors, in a group of people who are interested in dementia prevention. And we recruited this group from our Alzheimer's Prevention Registry, which is a registry where people can sign up in the area of Cologne if they are interested in dementia prevention. So the inclusion criteria were very simple: age above 50. Exclusion criterion was only whether there was a diagnosis of dementia. And the idea was to assess a number of risk factors, to provide individual feedback, and all of this within one day in a 2 hours session. So the 2 hour session was an informed consent process. Then we assessed the risk factors by medical history taking. We also did neuropsychological testing, blood sampling, a very short physical examination. And then this was analyzed and we provided a feedback to the patient on the same day. So this is the group we studied. So there were 162 individuals. You can see the average age was 64, slightly more females, quite high years of education, like it's typical for these volunteer samples. Mini-mental score was 29.5. 39% of individuals had a subjective memory complaint. and 50% had a cognitive complaint in any cognitive domain. Half of the sample were retired and the others were still working, and you can see the living situation. So most were in two-person households. And the family history were any dementia in the extended family, so any type of family experience, I would say, with dementia was 74%. Very concrete first-degree relatives with dementia was 26%. So this was the assessment. I will not go through all of the details, but you can see that we had, of course, medical history, medication, family history, a number of risk factor questionnaires, cognitive testing, physical examination, blood collection. And on the right, you can see the risk factor questionnaires we used. And you can see that beyond these 12 risk factors, which we have been discussed earlier, we also had something like, for example, proneness to distress or resilience scales. We had this a sleep scale and others and a loneliness scale to get a broader view on potential risk factors. This is difficult to read. It's also in German, just to show you how we provided feedback. So for example, if we found that one person had, for example, an issue with the diet, so very strong Western diet, at the end of the session, we provided a piece of paper where there was an explanation what is a Mediterranean diet. And then we said very politely and carefully, your dietarian style is not really in accordance with the proposed Mediterranean diet. And then we provided a sheet where it is explained how to change the diet to adhere more to the Mediterranean diet. And we had sheets like this for basically all risk factors, depending on what type of risk factor profile the individual had. So these are the distribution of risk factors we obtained from the medical history. You can also see that hypercholesterolemia is not a fully validated risk factor for dementia, but we included it. But you can see that hypertension is a big issue, and also, for example, things like hearing impairment and also depression. But this is only from the medical history. This is not from the time of assessment. So this is in the past or currently or in the past taken from the medical history. And this is taken from the actual assessments. And you can see that the most common risk factor here is related to nutrition. So it's obesity and non-adherence to Mediterranean diet. So obesity was operationalized by the hip waist index according to the WHO. So this may be a cutoff issue here, but maybe not. I mean, 80% of all males here are obese in Cologne. So this is quite a high number. And the second one is what we just learned about sleep is actually reduced sleep quality and also increased levels of stress. So now when we want to move forward to a personal type of intervention, we of course need to understand which are the most common risk factors and what are the most common patterns of risk factors. We cannot provide a specific intervention for 15 different risk factors. So we have to limit to a certain number of risk factors. And in our study, these on the right side in this graph are the most common risk factors we focused on. And on the left side, you can see that how many of these 6 risk factors are present in a single person. And you can see that the majority of individuals in our study had around 3 of these risk factors, 3 of these 6 most common risk factors. And you can see on the right that they somehow overlap. So we see something around diet, physical activity. We see something around blood pressure and obesity. And we see something around stress and sleep. So I think these are 3 areas which are not present as risk factors in every single individual, but they seem to cluster in a way. So if we would have interventions for, I would say, these 3 types of clusters, we would have kind of a spectrum to at least address the majority of our individuals in this study. This is the ApoE4 genotype distribution. There is a 30% is ApoE4 positive. This is higher than in the general population. The general population would be around 20%. So there's an increase of ApoE4 carriers here. And we also did plasma biomarkers. And this is the difference between ApoE4 carriers and non-carriers. I think this is, in a way, plausible that people who are ApoE4 carriers have a higher tendency to have some evidence for very early Alzheimer's disease. And these are the correlation scores of the cognitive performance and also of SCD with the global risk factor score. So the global risk factor score is the sum of all risk factors in an individual without ApoE, without the genetic part. And you can see that the higher the non-genetic risk factor load, there's a correlation with poorer cognition and also with higher subjective complaints. But there is not really a correlation with plasma biomarkers. The only correlation here is NFL, but this is after we correct this for age, this association is also not significant. So we do not see, even though we see a higher increase in ApoE4 carriers, we do not yet see in this population a correlation of the risk factors with the blood biomarkers. So to summarize, individual risk profiling is the basis for personalized counseling and risk reduction. I think that's clear. We have the technologies and methods. We could show that we find certain patterns of risk factors in a volunteer sample, which allows us to target specific interventions to certain, I would say, risk factor clusters in a way. And we found that the risk factor load correlates with objective cognitive performance and subjective worsening, but it does not correlate, in our study at least, with plasma biomarkers for Alzheimer's disease. So I think that's it. Thank you very much. This is the group who did the work. Thank you.
Thank you, Frank, for this very, very interesting communication. Thank you very much. We have time for one quick question because we are a little bit late. Please, woman.
So it would be very interesting to do the questions. So one is, Well, thank you very much. Great talk. Did you communicate anything to the participants about their AD blood biomarkers? No. And how did you threshold it? This is the first question. And the second question, are you planning, probably don't have it yet, any studies on the adherence to your recommendations?
Yes, so the first, we did not communicate the plasma biomarkers. We did communicate the ApoE4 genotype if the participant asked for this. We did not communicate the plasma biomarkers. We also did not use any thresholds for positive or negative because we do not have validated cutoffs. This was done by Charlotte Teunissen from Amsterdam. So we talked to her and she also said that we cannot really, in this study, provide a cutoff. We do a 6-month follow-up where we ask about the adherence to our advice, but since it was only the advice, it was not a strong intervention. Yeah, we are curious to see, and we don't have the data yet.
Okay, thank you very much, Frank. So we have to move to the next session, which is a very difficult issue. I think it's the issue of risk communication, and it's my pleasure to introduce Leonie Visser, who have a very good experience in the field, and we will learn definitely a lot of things with you. Thank you very much.
Thank you, Bruno, for the introduction and for inviting me here to speak to all of you. Good morning. My name is Leonie Visser, and today I will tell you something of what we know about risk communication, and I will try to provide you with some recommendations. So the World Health Organization has a definition of risk communication, which says that it's an exchange of real-time information, advice, and opinions between experts and people facing threats to their health, economic, or social well-being. And as we have already seen in the previous presentations, for example, biomarker tests could say something about pathological processes in the brain, which we could predict a disease like Alzheimer's disease. But today in this presentation, I would like to focus more on the clinical outcome, so the risk of developing dementia and how to communicate about that. Oh, there's a graph missing here. But I think here the Livingstone figure should have been presented on the right side. We've seen it already a couple of times today. And I think the important message or disclaimer that I want to make at the beginning of this presentation is that we know something about risk and that there is some information about potential modifiable risk, and we could inform people about that. But it's also great to mention and to take into account in a communication to patients or people at risk that there's much unknown and that it's really hard to predict why someone will develop dementia and another person won't. So why do we want to communicate about risk? First of all, and I think that's the most obvious one, risk information or risk communication will allow people to take preventive actions. And we know from research, for example, in oncology, that people's risk perception, so that they know that they are at increased risk, will stimulate them and create a greater likelihood that they will actually engage and adhere to lifestyle recommendations, for example. So that's why it's really important here. And what's also important is that people could anticipate the future. So it's not only for preventative actions, but it's also important for people to make decisions for their life later on. For example, do they want to go on a holiday, spend more time with family, for example? But I think most importantly too, in the context of care, we can't prevent dementia yet. So I think it's important for people as well to, for example, discuss with their loved ones, how do I foresee my future? How do I want, in case I develop dementia, how do I want care to be organized, for example, and what are my preferences in that aspect? People also want to know their risk of developing dementia. And I have some examples from research that we have done in our group in Amsterdam. And I think from memory clinics, we know that patients want prognostic information. And it's also patients with SCD who come to our memory clinics. They want to know what they can expect from the future. And in a cohort study with people with SCD from Amsterdam, in which people received their amyloid PET results if they wanted to know the results, we saw that that they didn't regret 6 months later, and there was no difference in regret scores between people who had amyloid positive or negative results. Another finding from our brain research registry in the Netherlands is that cognitively normal adults who are part of that registry, a large sample of that, we did a survey study, and 81% said that they wanted to take part in genetic risk research and that they wanted to know, so to receive their APOE status. So there's a large interest here as well from people themselves in knowing their risk of developing dementia. There's something wrong with all of my really nicely figures and graphs that I put in here. So you have to do it with text and just me telling you things. But the 4 things that clinicians also want to tell. And I think that's quite obvious that if you have patients coming to your clinic and ask them that they want to know something about their future, it's also nice that you can tell them something. And what we did is a survey across Europe in 160 memory clinic professionals actually completed the survey from 21 different countries. It was a project conducted in the context of LETTE and Eurofingers European projects. And we saw that many clinicians still hesitate to communicate about the AD presence in biomarker positive SCD patients, but that they say that they do discuss dementia in this patient group. And not surprisingly, like we see in the evidence, they still would appreciate communication tools or training, because it's really challenging. Indeed, I think what we've heard already, risk is a probability. It's inherent uncertainty. You try to predict something which is by definition not sure. And prediction models that we have today are also imperfect, so that even introduces more uncertainty into a consultation that you would have with your patient. So that it's difficult for patients to comprehend or understand, but definitely also difficult for physicians to communicate. And what we need is guidelines, and preferably evidence-based guidelines on what communication strategies maximize the benefits for the individual and minimize potential harms. What we did is we sort of tried to come up with the first draft of guidelines. And we didn't just think of that. We combined evidence, for example, also from other fields like oncology. We combined that with experience that we gained from the trial setting, from memory clinics. We had PPI workshops, so public patient involvement workshops, co-organized with Alzheimer Europe. And we also had working group discussions within the Brain Health Services working group to come up with these recommendations. And there were two really nice pictures of the two articles that were already published about that. But if you just search for Giovanni's paper, you will find them published there too. So these dementia risk communication guidelines, there are actually 12 of them, which were supposed to be on this slide. But I can at least tell you so that you really have to listen to me. And I think some of them are really logical. For example, to not use jargon and really try to use thank you. That helps a lot. So not to use jargon, but to use plain language and really try to explain it in a way that that people will understand. And I think even in my presentation, I already used jargon. It's really difficult. So to consciously think about how to explain this in layman terms is, I think, an exercise that we could all do at some time. But there's, for example, also more difficult things in there, which we potentially can't do yet. For example, the second one, to avoid exclusive use of qualitative risk descriptors like a high risk or a higher risk. I don't know if we have the data and the prediction models yet. And that was actually a point that Federico just made to me as well. Like, how can we actually provide them with the exact numbers? But that's a future that in the future, that would be nice. There's a couple that I want to highlight. The thing that I mentioned about presenting precise and defined risk information, such as percentages or frequencies, and support that also with visuals to really explain what it means to the individual. And because we know that these qualitative risks, like higher or more, and one person thinks that a high risk is 40% and someone else thinks it's 89. So I think it's difficult to explain this to patients, but it's important to make sure that they have the right expectations and that they really know what's going on. So we need to try to bring them a little bit more up to the expert level of understanding risk information. And I think graphs like this will help. And then the fourth recommendation, so be aware that order and framing affect risk perception, is, I think, really important. We often mention the risk of developing dementia, but the other side of the coin is that there's also a likelihood of people not developing dementia. And we know, for example, from the field of oncology, that it's really important to use mixed framing to communicate both. And results from a really large randomized controlled study that we did in the Netherlands show that the use of these risk communication strategies actually also improved individuals' information recall after the consultation. Then there's two final ones that I would like to draw your attention to. And the first one is to actively attend to emotions. It's a bad news consultation and people might not expect to be at higher risk. So it's really important also to provide space for emotional expression and to acknowledge them. And in this RCT that I mentioned, we also showed that providing emotional support during the consultation led to higher levels of satisfaction and trust in the physician. And this importance of support is not only during the consultation, but also towards follow-up. And there is a need for post-communication support, which was confirmed also in our consultations with the advisory board members from Alzheimer's Europe and by our individuals with SCD who received that amyloid PET results, in which we've seen that 45% of the amyloid positive individuals reported information needs like questions 6 months later. These were the risk communication recommendations that we published, but I do want to highlight a couple of more essential communication processes, because like I showed in the definition, risk communication is an exchange of information. And in contrast to the popular term disclosure, which more implies a one-way flow of information, risk communication actually warrants a two-way interaction. So the clinician shares information, but you also want something back. And before sharing any risk information, it's really important to inform about motivations, needs, personal situation of the individual that sits across your table, checking their knowledge, their prior knowledge, and their expectations. Do they expect to like solve all the problems or treat their disease or risk factors? Like what do they want? And are these expectations realistic so that we can manage them better? And I think shared decision-making here is important too, because there's so much uncertainty still. It's really important that you weigh pros and cons of knowing the risk together, and that you make a decision together if someone, for example, wants their blood-based biomarker results or not. And then I think I don't need to stress this for this audience, but it's really important for people who have memory complaints or subjective symptoms to check their understanding. And we know from research that that doesn't often happen, or that there's room for improvement, at least there. For example, by using a teach-back technique to ask patients to explain in their own words what the physician has just told them, and to make sure that that the patients also know that your goal is not to check them, but to check how well you explain the health information. So it's not to test their knowledge. For example, by telling them, like, I want to make sure that I explained the test results or your dementia risk communication clearly. And please tell me in your own words, how would you explain these results to a family member so that you really can test what did people understand, and do we still need to tweak or adapt or provide a little bit more explanation to correct it. In Amsterdam, we developed a platform of tools, which you can find here, to support the interpretation and communication in a memory clinic setting. It's in German and English and Swedish as well. And I think it's a really nice example of how tools might support these communication processes. It now includes a couple of modules, for example, with regards to shared decision-making, risk calculation tool to calculate dementia risk for patients with MCI, but the risk communication recommendations, we also incorporated them in a risk communication patient result page, which is, I think, nice if you just want to scroll a bit and see how it could look like. And it might be nice to develop such a platform of tools for the brain health services specific context too. Other future directions. I think we need a lot more research to generate evidence-based recommendations and tools. And I just mentioned a couple of them that I am involved in. So in the Netherlands, we have the Abort projects, in which we, for example, work on risk communication in the context of disease-modifying treatments. With Mia in Sweden, we work on the LETTE project, in which we ask people's perceptions and perspectives regarding communication via digital tools. And we have the Dutch Netherlands Dementia Prevention Initiative, in which we work on identifying communication needs and preferences and optimal strategies, especially among underrepresented groups who are often at the highest risk of developing dementia. And then the second thing I think is that it's important to raise awareness, to make sure that there is adequate knowledge and risk perceptions among the public, because those are the people who will come to our brain health services. So it's about citizens, but also about healthcare providers and potentially even other stakeholders that might have a stake or could do something in terms of dementia prevention initiatives. And in the Netherlands, there's two projects in which we try to gain more evidence in how to do, educate the public better. So in conclusion, risk communication is an essential part of personalized medicine approach to dementia prevention, and it involves an exchange of information. And we developed a guideline with communication recommendations. The QR codes, which is now visible, lead you to that paper. And I believe that tools could really support adherence to these guidelines, could help in practice to make sure that that conversations actually go in the right way. But more communication research is definitely needed also in the specific context of brain health services. For example, which communication strategies work best and for whom? How do people, especially those who need it the most, benefit optimally from risk communication? We actually want them, for example, to engage and adhere to prevention initiatives. And we might need communication strategies for like behavioral change there too. And can we support by means of tools, education, and communication skills training? With that, I would like to conclude and also thank the team from Amsterdam, but also from Mia's group at Karolinska and the medical psychology department from Amsterdam UMC. Thank you.
Thank you very much. Communication is open to question. Yes, please.
Thank you for your presentation. My name is Hans Pian. I'm running a memory clinic in Biel here in Switzerland. From my clinical work, I would like you to comment on two aspects, which I found important in my general daily work. Some patients are not quite interested in receiving the risk evaluation, not as much as the caregiver might be. Yeah? So in your work, does risk communication include the options not to communicate if the patient is not willing to for some reasons? This is the first point. The second point is patients in general are interested, also in my experience, to come to know their risks, but some refuse to have an elaboration on their risk. Like when it comes to the diagnosis, to assess biomarkers, to make a more precise prediction of the futures and the options, a significant number of patients refuse. So in my experience, it's about maybe 20 to 30%. So how do you address this in a concept of risk communication?
Yeah, thank you for the question. I think here the concept of shared decision making comes in, and it's not just about people just deciding for themselves, like I don't want to know this. It's also, I think there are a couple of steps in shared decision making process. It's also informing them, like if you would tell them the risk information, how it could benefit them, how it could also potentially harm them, so that they can make an informed decision about knowing or not wanting to know their risk. And I think in this point in time, what we heard today as well is that we do not have a crazy amount of evidence in that we can actually help them to reduce their risk and prevent dementia. So I think it's also a preference sensitive decision in that sense. But if people don't want to know the risk at all or don't want to know the details, it's up to them. I think there's a lot of people that are still left that want to be treated that we can help.
One last question, please.
Just thank you for the presentation, and just a follow-up question on our discussion that started yesterday. I've seen that most data that you provided come from countries in which people have higher level of educations, and so probably also a higher level of awareness of risk and what actually risk mean. So I've seen that at the end of your talk, you presented some initiatives that actually enlarge the number of countries involved and also extend this to minorities and so on. Do you have any idea of how we can adapt this sort of guidelines to other cultural systems, other minorities, and so on?
Yes, important question. And I think Esme Kreuk is here in the audience as well. She's a PhD student working on this topic in our group in the Netherlands, because I think it's really important that we know now a little bit about how you can explain risk to people who are white and well educated, but a larger proportion of people who are at risk of developing dementia have a lower social economic status or lower education. I mean, education is one of the biggest risk factors, right? So in that project, we really go into conversations with people from, for example, migration background or with lower levels of health literacy to find out what their preferences and needs are, and how we can make sure that the way we communicate and what we communicate is actually aligned, so that we can increase awareness there too. Yeah, but I think there's a lot that needs to be done there. Thank you.
Thank you very much, Leonie, for your interesting talk and for your expertise. So I think now, yes. We have now a break for 20 minutes and we will come back at 25 minutes and we will come back here at 11:40.
Ladies and gentlemen, please take your seat. We resume with a few minutes. There's some Mediterranean contamination, some delays, some second part of the morning. Bruno, toujours à toi.
So let's move on the second part concerning the risk reduction, multi-domain intervention, and who else than Mia Kivipelto could address this issue. She was the one who introduced the concept of multi-domain intervention. So you are the best person to speak about that. Thank you for addressing this issue. Everyone knows Mia. She's working in both in Stockholm and also in Finland. Okay.
So thank you so much for the kind invitation and introduction. My great pleasure to be here today. And first, I really need to highlight, Giovanni, your vision, but not only vision linked with action. And that's the difference. You are here, you have been putting forward this concept, brain health services, how we can translate and modify our memory clinics. And I think that is very timely initiative. I'm very happy to be here today. And of course, risk reduction. I think this is one of the key pillars in the health, in the brain health services. And I was thinking to discuss with you these three areas. First, the question, how much we can prevent dementia or cognitive decline, how much we have evidence. And the intervention, what is the right intervention? And you may know the answer. I believe it's multi-domain. And finally, how we can move on to implementation, how we can fill this implementation gap and the future direction. My vision is also precision prevention. This we already saw earlier, the numbers. Of course, no one really knows how much we can prevent dementia, but the latest Lancet Commission paper, the prevention potential was 40%. The new one, which has been now or is updated right now, is even higher, up to 50%. So you see the list of modifiable risk factors. It has been growing year after year. It's not anymore only vascular, metabolic, lifestyle. There are newer risk factors like hearing loss and even air pollution. Of course, we can discuss what is the evidence level. Are we sure these are really causal risk factors? And also, I think it's interesting to notice, you see these WHO risk reduction guidelines. The lists are not identical. There are differences. So WHO is using a bit more, I would say, systematic approach, maybe a bit more conservative, but there are some bit surprising findings. For example, diet is not part of the Lancet Commission paper. So it's good to keep in mind always how we evaluate the evidence, and there may be differences. Then, as mentioned, there are even newer risk factors. Sleep, stress, they are still not yet included in these papers. Visual impairment, so it's not only hearing, but it will be maybe more the multisensor impairment and impaired oral health infections. Important risk factors, especially when we are thinking our older populations. How we have been using this, it's also important to think not everything can be tested in a randomized controlled trials when the evidence level is enough. So what we are doing now, for example, is in the finger model, we are taking actually the social interaction, relaxation and sleep as part of the social activation finger. And the fifth finger, cardiovascular health, we take more holistic care so that we can even include hearing and visual impairment and these interventions. Well, it has been more difficult, as said, to translate these findings from observational studies to successful clinical trials. And this is not the case only for lifestyle interventions, but also for pharmacological interventions. You see here, if we are thinking the pharmacological interventions, we do have quite strong evidence that antihypertensive medications can reduce the risk of cognitive impairment and even dementia. The newest one here is the SPRINT MIND trial. For statins, hormone replacement therapy, NSAIDs, not evidence actually if something, even maybe some harmful effects. For single vitamins, not very strong evidence, like very weak and very controversial findings. And it has been now the movement to move more to dietary patterns, not only single vitamins. Physical activity, cognitive training, Mediterranean diet, these single domain lifestyle factors. There are some positive signals in the shorter term trials. But as I say, the direction has been to move to multi-domain interventions. And I think it makes sense if you think the list of modifiable risk factors. We need to target several risk factors and mechanisms at the same time to get an optimal preventive effect. And here we have indeed many or several, I would say, pioneering studies in Europe, lipid diet with the medical food, finger-mapped pre-DIVA, and also MIND-AD. And you heard already about these three bigger European studies from Philip. We have been working together trying to understand what are the differences, what are the lessons learned from these three studies. And these three lessons learned I have highlighted here are timing. It seems to be good to start early. The second one, target population, focus on at-risk individuals who have potential for improvement, who have some modifiable risk factors. And then the intervention. Well, do the right thing and do enough of it. The intervention needs to be intensive enough that we can see the effects on the brain. FINGER, as said, was the first large long-term randomized control trial where we could show that this multi-domain FINGER model could indeed reduce the risk of cognitive decline. And I think the 5 fingers, which you can see here, nutrition, exercise, cognitive training, social activities, and taking care of all vascular metabolic risk factors, it captures the main modifiable risk factors we could see earlier. We had cognitive benefits for total cognition, but also for processing speed, executive function, and complex memory. There were 20% lower risk for cardiovascular events, a lower risk for functional decline. Quite interestingly, 60% lower risk for chronic diseases, especially multimorbidity. Better health-related quality of life, and even health economical benefits and reduced cost for healthcare. So we can see the effect for brain health, general health, individual, and on societal level. Thinking or looking a bit more closely the vascular factors, because this is our hypothesis, of course, that this may be one of the main mediating pathways. There may be others as well, I believe so, but here we have strongest evidence so far. We could see that the same finger intervention could reduce the risk of cardiovascular events. It was stroke, TIA, and coronary events combined. And quite interestingly, those persons who had previous history of CVD, the risk reduction was even higher, up to 50%. And I'm thinking the concept brain health services, these are maybe the persons who come to us. They have risk factors. So clearly we have here a lot we can do for brain health in I would say in general, not only cognition. And here we could also use the follow-up data up to 7 or 8 years. So for some outcomes, you may need a bit longer follow-up time. How about dementia? Can we have that as an outcome in our trials? Well, I don't really think so. It's difficult to have a trial starting so early and having dementia as an outcome. You need maybe 20 years or so. But we can have estimates. And we have been doing this in the finger trial. We had 2 different dementia risk scores, the GAID risk score and the LIPRA risk score. And we could see that the intervention was reducing the estimated dementia risk based on both of these risk scores. And that gives a kind of hope that there is really this potential for also reducing the risk of dementia. For future research, I think we would really need to develop even better, even more sensitive tools to capture this prevention potential and how much it can affect the dementia risk. Then comes the question, who are the persons who get the most benefit? This, I think, is very practical if we start to get the persons to the clinics. Well, in the finger trial, we tried to see that. So we checked different demographic factors, vascular factors, cognition. We did not see any significant differences. And in a way, I think this is good findings because that means that we can generalize the findings to this wider at-risk population. Of course, this is a Finnish population, homogeneous, and that's why we need to have the worldwide fingers and other studies to really have a bit more diversity for these findings. One observation, though, we had from the finger was that persons who had depressive symptoms did not get as good effect. And we can think that if you have depressive symptoms, it may not be as easy to adhere and do these changes. So from the clinical point of view, these persons may need a bit more extra support. One difference, which was already mentioned, was the question, how about if I have the genetic risk, APOE4? So we could see that APOE4 carriers, as said, if something got a bit more clear effect, but this was based on the stratified analysis. Interestingly, MAP trial, there are similar type of findings. There have been meta-analysis, and as you can see here, that is showing the same picture. APOE4 carriers may get, if something, a bit more effect. And very interestingly, at AAIC, the Japanese finger trial, which was also positive among APOE4 carriers, showed the same thing. These persons seem to get a clear benefit. So now we are trying to do meta-analysis based on these 3 studies to get even stronger evidence base. Then one more question, what's the dose? What can we recommend for our persons? What is the intensity needed to get the benefit for the brain health? Well, to be honest, we don't know exactly how much or how little you need to do to get the benefit. But what we could see in the finger trial was that there was a dose-response relation. So persons who attended all these 5 fingers, at least 50%, then we started to see the clear benefit on brain health. So you don't need to do everything, that's maybe not realistic, but clearly supporting the longer term adherence in the implementation is very important. And there are some list of some factors what we have been thinking was behind why finger was successful from these trials. We had both group activities, including other persons, is always good if you want to make a lifestyle change. Individualized, concrete counseling. People know the theory, but they need something they can own and how they can change their life. Educated staff who can really give this advice. Small steps, you don't need to change everything at once. And positive feedback. People need to hear that it's not only that you can prevent dementia in 20 years, but they want to see the changes immediately. Finding own motivation, empowerment of own health, and also importantly, community support. We need to try to make the healthy choices the easy ones for all, not only highly educated persons. So that's not always so easy. Well, then a few more words about the next directions and where we are. We have the worldwide fingers, as we heard, with 62 countries. This will add the diversity. We will learn so much more what is the best way to increase brain health. And there are some positive findings, not only finger. We have Jamie, Australian study, not yet published, I think, but massive study using more new technology and with positive findings as well, which I think is very, very nice finding. And altogether now, more than 18,000 participants. So that will give more power for our analysis, for example, gene-environmental interactions. And this is the direction where we are moving. We want to adapt, improve, optimize the multi-domain interventions so that it can really fit to the individual and population. And we want to test it for persons who have early Alzheimer, combination therapies, using new technology and implementation. So it's kind of constant feedback loop. And one more question of what we kind of learned from these studies, what we often could get from our patients. Is it too late when I have got the diagnosis? Can I still do something with the lifestyle interventions? Well, we of course need still more studies, but now we at least have findings from MIND-AD and many other studies. In MIND-AD, we adapted the finger interventions for patients who had prodromal AD. We also used medical food. And there was very good adherence for all these 5 fingers and also results. lower vascular burden, increase in healthy diet pattern, and even improvement or better CDR sum of boxes after this intervention. So based, it's never too late. The effect of this intervention is not stopping after the diagnosis, but we should try to give more support for these persons. And this has stimulated us to move on, upgrading Finger to Finger 2.0 to be more individualized. And why not to combine with disease-modifying or other drugs when needed? So the precision medicine, giving the right treatment for the right person at the right time. And here we have the first trial up and running called MedFinger, where we combine diabetes medication metformin with Finger. There are many links between diabetes and Alzheimer, but metformin has also many other mechanisms of action. We use here ApoE4 enrichment, and we use two-step randomization, so that persons who have certain eligibility criteria will get metformin, not all. And I think that study design, I see this as a model for the next generation of combination therapies. It could be like a platform design where we add also treatments like GLP-1, anti-inflammatory, and maybe amyloid. I'm thinking the vascular effects, we might be able to reduce the side effects if we could combine Finger lifestyle and amyloid therapies. And this could be the direction, Finger plus different things. And we discussed yesterday about the drug pipeline. 28% of the drugs tested for AD are now repurposed drugs. And actually the newer number is 40% according to Jeff. So there is a lot of different type of treatments we could add to this cocktail. So finally, just two more slides about the importance of the implementation. We will come back to this after the lunch break, but this is clearly the implementation gap. We need to speed this up. And as you said or mentioned already, Giovanni, all levels are needed. Memory clinic, this secondary level, but also the wider municipality level. And tools, that's what persons normally want to have so that it's easier to implement. We are working now with something called Finger APC, a material we are creating. We want to focus on family fingers, not only the individual, but the whole family. And one concept, what I really like, is high five for life. We want to go to even earlier population, to schools, because that's where you shape your lifestyle. So I would say it's never too early to start these type of interventions. And I will leave you with this slide. There are things happening which may help us to speed up the development. I'm very happy to announce that we have got this big new initiative from IHI called AD Riddle that focuses on real-world implementation, both what it comes to digital tools, blood-based biomarkers, and multi-domain interventions, both pharmacological and non-pharmacological. This project will run 6 years, so I think that will give a framework in Europe to work in this direction. If you want to read more, we have also a new paper focusing on this topic. So my take-home action points. I think risk reduction is possible and is already happening, like you said, Giovanni. We need to be ambitious with prevention. We need to be realistic, but we need to have the goal that we can do. And I believe that if we have the life course perspective, if we have the broader picture, not only neurodegeneration, but also vascular and increasing brain resilience, we can do even more in the future. And as I said, it's never too early, it's never too late. We can always do something, but one size does not fit all. And that leads us to the precision prevention idea for the future. And again, broad collaboration, joint actions are needed. So that's why I'm very happy to be here today. I see this as a start for this new era from services, what we can really do. At the end, I want to thank all my colleagues in different institutes, and I want to thank you for listening.
Very, very impressive. Very impressive. Frank?
So thank you very much for this great talk. regarding the markers, the biomarkers for these multimodal interventions, which do not act only on the brain, but on the full body. I think there is a huge approach of aging, biomarkers of aging, senescence markers, which are non-specific for AD, but are probably main drivers of cognitive decline in addition to amyloid and tau and so on. So what is the current status of looking at general senescence biomarkers in multimodal intervention? Because I think that they could predict responders, inform about intensity of required interventions, and so on and so on.
Yeah, that's a very good question. And indeed, this is an area we want to focus now. We have been collecting, luckily, a lot of blood samples so we can analyze markers which are coming. And we also from the brain, like this brain age clock. So we have some preliminary findings indeed showing to that direction that finger type of intervention can affect this more broader aging related process. Age is still the highest risk factor for dementia, so I think that's important. We have been showing that finger intervention can counteract the shortening of telomeres, so that's also one thing. And now we are analyzing also the more traditional Alzheimer biomarkers, a lot of inflammatory biomarkers, metabolomics, proteomics. The challenge is almost there is so much biomarkers, so I don't know how to analyze all of that, but that's absolutely the direction, understanding what are the mediating pathways that I think is needed now in the multi-domain field. My hypothesis is that they may be several. Vascular, I believe there is something also for Alzheimer. In some studies, we have seen that for phosphorylated tau, inflammation, oxidative stress, and increasing the brain resilience. So you can be more tolerant for the Alzheimer changes. So I think all these can be there, and that's maybe the beauty. Then you even small changes here and there that can really increase the impact.
Is there any other question? Okay, please, Leonie. Microphone for Leonie.
Thank you, Mia, for the talk. I was just wondering, because we heard of disease-modifying treatment, like maybe people stop at some time and they get they start again when the levels go up. I was wondering how you would foresee that for multi-domain lifestyle interventions. Did you try like a refreshing course at some point during the follow-up to get them up to speed again, or?
That's a very good question. How long time you can think the effect is there when you have stopped the intervention? That's also the challenge we have had in finger. We have 2 years intervention and nothing really happened after that. If we would have had the resources at that point, it would have been nice to have some sustainable, some motivational things. And that's maybe what I think is needed in real life. You have first the more intensive time when you learn the new lifestyle, and then some maintenance sessions. Exactly how much is needed, we don't know. New technology could help there. You don't always need to have face-to-face. It can be also digital visit. And that I think is something we need to discuss more now, how we move on in this field.
Okay, thank you very much, Mia, for this very, very impressive talk. So now we will address another issue, because in parallel to this multi-domain intervention, that might be pharmacological intervention in the future. And I think we will have a video with Jeffrey Cummings. Everyone knows, of course, Jeffrey Cummings. He is one of the leaders in the clinical trials with new disease-modifying therapy, and he will make the point concerning this possibility to think about these kind of drugs in the future for prevention, pharmacological prevention.
Hello, everyone. Jeff Cummings here. Sorry that I'm not with you there, but it's great to be with you in this virtual way. Giovanni asked me to talk with you about Alzheimer's risk reduction from a pharmacologic strategy point of view. Thank you very much, Giovanni, for inviting me to be a part of this really vital discussion on brain health services for prevention of dementia. Here are my disclosures. I've consulted for a large number of companies in order to try to help them with drug development.
our 181 reduction is the outcome of that trial. This is a 1.5 year feasibility.
good talk, and as he says, provocative talk, but very interesting, I think. It's incredible. Now, unfortunately, there is no possibility to have a question. Just would like to make a remark, if you agree. It's a very good talk, and we should keep it, because for the future, it will be interesting to have this talk. Now, the point is that this is science fiction, of course. This is very interesting. The problem is that we will have to treat cognitively normal people with disease-modified treatment that we know that they have some side effects. So we have to relativize this information based on the fact that we will probably, if we follow this, treat normal person who have no problem. Some of these will have no biomarker, with treatment that are not so simple. So we have to keep in mind the side effects of this treatment. Some of these, as you know, there have been some death. So we have to be very careful with that. But anyway, that's interesting, and I'm very happy to have to attend this beautiful talk. Okay, so let's move on to the next speaker. Sorry, okay. Okay, it's Andrea Guevara, who is working, I think, in Italy. She is working in Italy. Now, where are you working?
In Lausanne.
In Lausanne, okay. And I'm sorry, because I don't have my... Okay, Andrea, sorry. And you will speak about your expertise in cognitive enhancement, cognitive training in the team of Gilalali at Lausanne. Thank you, Andrea.
Thank you very much. Thank you very much. I totally understand that you remember better who Mia Kivipelto is, and I'm indeed very impressed to be here after you. But I'm working with Gilles Lalali. I'm a neuropsychologist, and I was asked a few years ago to work on non-pharmacological intervention and what is the impact of this non-pharmacological intervention on cognition in general. So just all right, it's all over the place. So just to be on the same page, you had a lot of different definitions that were sometimes linked to biomarkers, sometimes not. And here, just to simplify it, because I would be talking about subjective cognitive decline, just to say that the subjective cognitive decline I'm talking is just about clinics. So people that complain about memory or other cognitive issue in daily life, but whenever they come to memory clinics and we do some cognitive tests, we don't find anything. So as you noticed, it doesn't mean that they don't have anything. It means probably that we have limitation in the way we assess them. So you heard a lot about it, but as it was said before, it's about it's key in memory to repeat things, but indeed, what we can see is that dementia is not a fatality. It means that through life, if you change your lifestyle, as it was explained very thoroughly just before, then you can have an impact, but not a small impact, a really huge impact. So that's very, I find it's very encouraging that we can act on it, but how do we act on it? So that's a good question. And I think there are several ways to act on it. So what was asked to us was to do a grade analysis on studies on cognition in the patient having a subjective cognitive decline. So it's pretty hard to do because, as you know, subjective cognitive decline was defined in 2014. So before we chose a patient that the people that were complaining about their memory, but the definition of the participant is not that clear. But still, we took all the non-pharmacological studies, randomized controlled studies that were assessing cognition at the end of the day. So the way it is, the grade actually methodology, it's very close to the Cochrane methodology. It's about quality of evidence. It was asked what was the quality of evidence of these studies. So it's about that. The way it's like you have several intervention, or you have one intervention. In our case, it's several intervention, and then you check on the outcomes that you choose if these intervention have an impact of it. So the intervention that we found in our study was interventions such as neuropsychological intervention, both strategic learning and cognitive learning. Cognitive training. So strategic learning, it's more about how can we find strategy so that the issue in memory that we have in daily life doesn't have an impact really in our action, in our activities. Whereas cognitive training is more about training a specific function such as attention. For example, in the serious game, you have some cognitive training, specifically on cognitive training. And then you can do psychoeducation, because when people come to you, even if they have like disorder in the memory skills, they say, okay, I don't have memory anymore. But then when you do the test, you realize that maybe in 4 systems of the memory, they have totally preserved memory and only one of them has an issue. So you have to explain that to the patient. And then mindfulness is meditation, the mind motor training, aerobic training, and lifestyle program intervention. And the outcome that we chose, they are based both on the literature and on what makes sense for a clinician. So the outcome of interest that interest cognition were global cognition, subjective memory, objective memory. Subjective memory is the complaint. Objective memory is whenever there is, when we assess it, we have a result on this performance. Meta memory, how the way that the patient assess their own or judge their own memory, and executive function and attention. But what is really what we call the Graal in French for a neuropsychologist is not really how they improve what you've been trained, but how does it happen in daily life? How is the generalization? Because we really don't care how they improve on one task. We do care how it happens in daily life, actually. So that's about the transfer. And then motivation, as it was noticed, mood, anxiety, and depression, and quality of life were also the outcomes of interest. So actually, this grade methodology was really interesting to do, because we looked at all the studies, all these randomized control studies that are supposed to be the very high methodological studies, and we really judge on every single aspect, the risk of bias, but also the way that they select the patient, the way that they show the results, etc., etc. And then we could judge if we look at one outcome of interest, such as subjective memory. We looked if the quality evidence is low, very low, actually, low, moderate, or high on this outcome in general. So this is a table that I simplified only on the results that were significant. But as you can see, and I'm going to try to do the pointer, you said it was, that's a big pointer. So here, as you can see, you have the outcome of interest, okay, such as subjective memory, objective memory, executive function, etc. And here you have the training intervention, and I simplified because that were the training intervention that had an impact on one of these outcomes of interest. And the dot, it's a very complicated table. I'm sorry about that, but I'm going to show you the whole way. So the dots, they are either in the green side or in the pink side. Each dot represents one study, one of these randomized control study. And whenever it's green, it means that it shows a positive and significant impact on this specific outcome, such as in subjective memory, the cognitive training showed that in 4 of these studies, a positive and significant impact. So actually, the color is about is about the GRAIN methodology. It means that on subjective memory, the results were low quality of evidence, whatever intervention it was. So subjective memory, objective memory, global cognition, proximal and distant transfer, generalization, mood and quality of life, and motivation, there were really low quality of evidence. Whereas on executive function and attention, there were moderate quality of evidence, which is really good already. And meta-memory, there were very high quality of evidence. So this is actually linked to, in general, consistency in the results. It means that whenever the results are not really consistent between the studies, then it drops very quickly. Or just if one of the indicators, such as the way that the results are shown, if they are not perfect, like it drops down. But what we found actually is that when we did like some kind of post-hoc analysis with non-parametric data, and we compared, we tried to analyze really the different training intervention on this outcome of interest. What we noticed is that when we do cognitive training, then we do have an impact, and with the moderate quality of evidence, on executive function and attention. When we do strategic learning, in that case, we have an impact and significant impact on the objective memory. It doesn't mean that the lifestyle doesn't have an impact. We know it does. It doesn't mean that aerobic intervention doesn't have an impact. We know it does. It's just that on that review, because we were taking only subjective cognitive decline, only randomized controlled trials, then that's what we found. But then when you propose some training, cognitive training, and then you do, for example, 9 sessions or 2 sessions or 5 or 8, and then you stop. First of all, we know that the quality of life of the patient will drop. And second of all, actually, if there is social isolation, I mean, it doesn't make any sense. You can do whatever you want, such as aerobic, and then you stop the aerobic and the patient is not doing any more exercise, then it doesn't have an impact, a long-time impact. And about social isolation, I think it's very important that we fight social isolation at the same time, because we know that social contact, when you have social contact, then you have a better cognitive function. We know also that the impact of social isolation has, on this study, shown a better impact than the genetic risk, which was like a big genetic, how do you say, genetic risk taken on 10 different indicators, I think. And then we know also that when you reduce your social contact, then you increase your stress, you increase the depression risk. There is an impact on the sleep. We spoke about the sleep, it's very important. And you reduce cognitive reserve. Whereas when you do social intervention, group meetings, have a coffee in group, for people over 60 years old without cognitive disorder, then you improve the global cognition, the brain volumes. So I think either you believe Churchill, who I saw was with a cigar also on your picture, who said that an apple a day keeps the doctor away, but he added, as long as you aim well. So either you believe Churchill or you believe science. You believe that lifestyle has an impact. You believe that dementia is not a fatality. And when you use specific interventions such as cognitive training, strategic learning, then you will have an impact on specific aspects such as executive function, attention, and memory. And I think you have to use both, actually, because we know that memory is not working just by itself. We know it needs attention, it needs executive function. So probably the best is to do both. But what is very important also is to fight social isolation and to maintain the benefits of the training. For that, in Switzerland, the French part of Switzerland, we have a program called CareMent. And this program is exactly about that. It means that we propose to the patient who needs cognitive training, a neuropsychological intervention, or physical intervention or speech therapy, we propose them to enter to the care man's program. And then there is a care manager. We have one here in the room that follow the patient and see what is the leisure activity that he will enjoy to continue, just to maintain actually benefits, such as this patient had a physiotherapy, then what does he like in terms of physical activity? And this care manager will find actually a physical activity that will be highly, that the patient will really like. And then we will follow actually on several indicators, such as quality of life, but cognition also, and anxiety and depression. And for the moment, it's working, we think so. So thank you very much. I would like to thank Mélanie Bielin in particular, who worked with me, who suffered with me on this great methodology paper. And I would like to thank also Professor Demenet and Professor Halali, who supported my work. And thank you very much to all of you for your attention.
Thank you very much. Thank you very much, Andrea. I think we have to move on because we are running after time. Thank you very much for your beautiful talk. And the last talk will be from Giacomo Koch, who is an expert in the brain stimulation, non-invasive brain stimulation. You are working in Santa Lucia in Roma. So thank you for telling us more about the interest in this approach for those who are complaining about their memory. Bye-bye.
Thank you. It's a great pleasure for me to be here. So my goal is to describe the potential role of non-invasive brain stimulation in the context of next generation memory clinics. This is the outline of my talk. I will start mentioning some theoretical basis for the use of non-invasive brain stimulation. I will describe briefly current clinical evidence in patients with Alzheimer's disease, mild cognitive impairment, and subjective cognitive decline. And finally, we'll try to discuss with you some potential roadmap for the use of brain stimulation in the next generation memory clinics. So this is what we always consider when we deal with non-invasive brain stimulation. The idea is that we are interacting with synaptic function, and synaptic function and dysfunction is key in the context of cognitive impairment, and it's key in the context of symptoms onset of cognitive decline in Alzheimer's disease. So we all know that when synaptic function declines, is exactly close to the moment in which cognitive symptoms appear. So, sorry. What is also has been described and understood in the let's say past of 5 to 10 years is that there is a progression of synaptic dysfunction in Alzheimer's disease, in neurodegenerative disorders, that starts at a circuit level, neuronal level. We can observe changes in neurotransmitters, we can observe reduction of dendritic spines, and at some point there is a transfer of impairment that moves in at a circuit level, and after a few years this dysfunction involves broader areas, so we can talk about brain network level dysfunction. And this model is important, and what we think is relevant here is to have clear in mind which are the main pillars of synaptic dysfunction in the context of Alzheimer's disease. First of all, we know how hyperexcitability is relevant. So the imbalance between excitation and inhibition has been described in animal models and has been confirmed clearly in clinical studies. So hyperexcitability is the first. Second, very important, disruption of gamma activity. We all know how gamma brain activity has a role in cognitive function, especially in memory, and is related to cortical plasticity, and very important also for intra-brain communication. What happens in Alzheimer's disease and in cognitive impairment is that this very efficient circuits is actually impaired. And the third very important conceptual pillar is the impairment of brain plasticity. We all know that from this perspective, Alzheimer's disease can be considered a disorder of synaptic function, mainly affecting synaptic plasticity, which is itself the neurobiological basis for learning and memory. And people that are familiar with the literature, the work of the group of Silko know well how much has been clarified the impact of beta oligomers and tau protein in actually abolishing synaptic plasticity, long-term potentiation, and so on. And this has been in the past year clearly replicated in patients with Alzheimer's disease by using, for instance, repetitive transcranial magnetic stimulation. We were able to describe this abolishment of long-term potentiation also in patients that, interestingly, was not related to aging. And very important also, as I described in my first slide, is the transfer from neuronal level, circuit level, to broader dysfunction of connectivity. And especially when we refer to Alzheimer's disease or to memory in general, we all know how relevant is the hormone network, which is responsible for memory function, and not only has been described to be associated with early deposition accumulation of beta, tau oligomers, and its dysfunction has been confirmed using different neuroimaging methods such as PET or fMRI. We can also now use more advanced technological tools such TMS in combination with EEG to actually map the activity and connectivity within this network. And as you can see in this picture, there is a clear difference between healthy subjects and patients with Alzheimer's disease in which there is a relevant breakdown of connectivity. So one magnetic pulse cannot induce a nice propagation in the circuits as we can observe in healthy subject. And the idea is that if we enhance our technical capabilities, we can try to actually identify fingerprints of connectivity and excitability at a single patient level. And what we are now starting to see is that actually there is a huge variability in the activation of these networks that can be probed using TMS and EEG in combination with neuroimaging, and we can start now to describe more in detail at a single patient's level what's actually wrong and which is the network that is less efficient. And this is actually, this background we think is important because if we want to consider that we have this big opportunity to use non-invasive brain stimulation methods to counteract synaptic dysfunction, we actually have to keep in mind that there are different methods that physically interact with the brain, may promote plasticity with different perspectives. For instance, repetitive transcranial magnetic stimulation is the most investigated, but also transcranial direct current stimulation or transcranial alternating current stimulation. And recently, focused ultrasound has been also introduced as another potential methods to induce plasticity in the brain. But the idea is that all these different methods may actually be relevant in this context because they could enhance cognition, acting on brain plasticity, increasing game activity, and network connectivity. There is also an emerging literature which is very interesting that is confirming this hypothesis at an animal in animal models, both using TMS, TDCS, and TACS. There is evidence that these methods may increase GAM activity, reduce amyloid load, neural inflammation especially, and therefore we are looking forward to understand better mechanism of action of this interaction between non-invasive brain stimulation and underlying pathological changes occurring in Alzheimer's disease and aging. Well, which is now the current clinical evidence? We are aware that in the past 10 or 15 years, there have been several attempts to use non-invasive brain stimulation in patients with Alzheimer's disease. Overall, the recent meta-analyses are clearly showing an advantage on cognition. If you use repetitive TMS, this advantage seems more robust as in comparison to TDCS, but again, the indication are positive, and there are also very preliminary and initial studies performed in patients with subjective cognitive decline that are showing improvement of memory. However, we know that these studies were limited by a short duration of stimulation. Most of the studies were, even in patients with Alzheimer's disease, were using stimulation session lasting few weeks. So recently, we tried to expand this concept into the context of a clinical trial more related to the field of LCT in Alzheimer's disease, and we use our personalized TMS EEG approach in order to define the better parameter of stimulation in these patients, and we actually were observing potential long-lasting effect up to 6 months, and more recently we are expanding to up to 1 year. So the idea is that if you keep stimulating the brain of this patient during a longer period of time, up to 6 months or 1 year, you can actually see more profound effects in terms of cognitive functions that can be maintained functioning for a longer period of time. And notably, what we know is that by using these neurophysiological biomarkers, we can also map changes in activity of plasticity in the network, and we can see an increase of gamma. We can see that the connectivity is maintained, and recently we are starting also to observe that there is a reduction on atrophy. So even at the structural level, restoring plasticity seems capable to counteract atrophy, at least in the network that is stimulated. And also there are preliminary findings showing that, for instance, TACs could also reduce the burden of tau, but these are very preliminary findings as well. So we need to understand more, which is the impact on this mechanism of action. And again, I want to mention how in this field personalization is important. Using non-invasive brain stimulation, you have the unique possibility to actually modulate network at a single patient level with specific features. And we are now working in a large European project actually to improve our knowledge on this personalization and stimulation protocols, combining different techniques like MRI, PET, TMS EEG, and so on. So this is another challenging aspect that needs to be considered when we could now think about transferring this model in the next generation memory clinics. Professor Kivipelto described well the importance of multimodal information and multimodal therapy. So we think that brain stimulation could actually play a role in combination with all the other important therapies or changes in lifestyle that can be adopted. And the fact that actually TMS and transcranial electrical stimulation are now considered viable and safe could be transferred in the context of prevention trial. And the idea is that we can now know better which is the target to be stimulated, because we know that during healthy aging, there is a progression of memory impairment, cognitive function impairment that is associated with different network, and target potentially one or the other network could be important at a single patient level to obtain the most relevant effect. And what is also challenging here is that not only we can decide which is the best target, but we have also to decide which is the best tool. So is it better to use RTMS, TACs, TDCS, focus ultrasound, combination of these methods, use these methods in combination with cognitive training, which is the best solution? This is challenging, but we think that there is a big opportunity in the future to get to the best combination in order to achieve potential beneficial effect in terms of prevention in patients that are at risk for dementia. So obviously there is we are facing huge complexity, and I'm just refining here a few concepts that are quite obvious but important to be underlined. So first of all, we need to establish the feasibility of the use of TMS, tax, or focus ultrasound in memory centers. We need to define personalization for programs of prevention based on needs. And we need to elaborate a model that's also very important. We need to control the application of NIMS in memory centers and try also to extend this at a home-based fashion that it could be important to expand the use of these protocols. And finally, we need to test the efficacy of non-invasive brain stimulation in combination with other brain health initiatives. Obviously, sorry, these slides have been a little bit disrupted, but they were just reiterating the same concept. The overall goal and challenge here is also related to consideration ethical standard. We know that we have to discuss with the public and with the patient, so the importance of using these methods. There could be some concern. People may think these are risky and could impact on their brain health. So, for instance, in this European project, we are now seriously working on the ethical aspects of this initiative, but we think that extending the knowledge, the scientific background could be very important to make this opportunity real in the context of next generation memory clinics. So this was my first slide. I would like to thank you all for your attention, and would like to thank all my collaborators. Thank you.
Thank you very much. Do you have some question? Yes, Stefano.
Thank you, Giacomo. Great talk. I think that in my experience, one of the greatest problem is the prediction response. Mm-hmm. So among them, and the fact that you have so many degrees of freedom, I mean, in terms of localization and methods. So what's your take about the possibility to predict it? You think that, for example, computational model is a good candidate for that?
Yeah, I think so. So artificial intelligence, the idea that now we can get, for instance, using TMSCG, we can get a huge amount of data, and we might be able to process with a more modern approach to get more information. This could provide us biomarkers of potential efficacy that so far has not been used. Thank you for the question.
Just a short question, and it's possibly a bias because our discipline, imaging with PET, is often pointed or identified as the costly procedure. I was wondering if you have estimates of costs of these type of intervention, because it seems to, imply a lot of specified personnel, a lot of appointment, a lot of intervention over time.
Yes, it does nowadays, especially if you refer to transcranial magnetic stimulation or TMS. But for instance, if you use TDCS or TACS, these systems are much more cheaper. And the idea is to build solid bases with a model that is maybe more costly, and then to derive and expand this to, let's say, more cheaper, affordable environment. Yeah.
Thank you very much. So we're going to close this morning by conclusion. So we heard a lot of, thank you very much. We heard a lot of very interesting concept. I try to summarize the main concept on one slide. If you would move forward. But most important, now we have to practice. So we have to walk until the buffet, trying to make social interaction in French, English, and maybe Italian. If you can switch the language, it's going to be better. For the food, you're going to have snack with metformin, I think, for Mia. For drinking, there is a fountain of anti-amyloid drugs for those who want to try. And yes, now I'm going to, just before to go, I just want to leave the floor to Giovanni just to present you the afternoon. So thank you very much for the question. Thank you very much for the participation.
Thank you, Gilles.
there's not much more I have to say, just to underline that today what we heard is the ingredient for the recipe for a patient journey. You know, one thing is scientific papers, is writing, doing individual projects, individual research projects. Something else is concocting them into a patient journey in a memory clinic, in a traditional memory clinic, or as we want to do in a second generation memory clinic. What we will address in the afternoon, which is a closed session for professional, is to talk about the patient journeys, what we will act, what current experiences are really doing in real life. It's a so-called closed session because not because we are talking, we will discuss secret things, conspiratory issues, but simply because we don't believe that it's going to be interesting to the general public. It will be interesting only to those who are in the business, but whoever one is happy to stay, please stay. And then this is really all from me. Let's go have good food. And for those who do not have intermittent, who do not follow intermittent fasting, of course, and good drinks. Thank you for being here, and you have a good day.